Okay, so yesterday we have discussed all the pathology part of the hematology and oncology, and from today we will start the pharmacology of the hemo. Okay, so first are the direct thrombin inhibitors. Okay, and these are the anticoagulant drugs. Okay, so direct thrombin inhibitors, they will inhibit the factor 2, the clotting factor 2 of the clotting pathway. Okay, and these drugs are the bivalirudin, agatropine, and the dabigatran. Okay, that they can directly inhibit the clot associated as well as the free thrombin. Okay, and so you can use these in the various thromboembolism cases in the AFib, because you know that in case of arrhythmias you will be having this the formation of thrombus and then the formation of embolus in case of dysarrhythmias, and that's why you always need to give the anticoagulation therapy in case of arrhythmias, right? Okay, and they can also be used in case of heparin-induced toxicity, right? Because you guys know that heparin actually inhibits a factor 10 and factor 2. Sometimes it can also lead to the HIT. Okay, in that case, you cannot use the heparin. And because the heparin is inhibiting the factor 10 and factor 2. So if you inhibit the factor 2, then it will be the same effect, right? So these drugs will be used mainly in case of heparin-induced toxicity. Okay. What are the adverse effects? Of course, the bleeding, right? These are the adverse effects. And you can give the patient PCC or the antifibrinolytics, okay, if no other agent of reversible uh, is available. Okay, so these things can also be given, the antifibrinolytics or the, for example, a transaminic acid in case no reversible agents are available, right? We have known that about this transaminic this acid already, right? The transaminic acid.
Yeah.
And one more acid there was, what was it called? Remember? Transaminic acid and one more acid we have discussed, which can reverse the this anticoagulation part.
Aminocaproic.
Aminocaproic acid, yes. So these agents can also be used, right? Whenever you have the bleeding complications. Any doubt on these thrombin inhibitors?
No, thank you.
Just give me a second. Yeah. So first of all, it will bind to the antithrombin 3. Okay. Then after binding to the antithrombin 3, it will make this antithrombin 3 bind to the factor 2 and the factor 10 mainly, right? And that's how this heparin actually inhibits the factor 2A, which is a factor 2 activated or the thrombin, and the factor 10 activated. Okay. It is generally used whenever you need the immediate anticoagulation, for example, in case of a pulmonary embolism, in case of any acute coronary syndrome, in case of myocardial infarction, in case of deep vein thrombosis, right? And you can also use this happen in the pregnancy because it cannot cross the it cannot cross the placental barrier. Okay. And whenever you give the patient heparin, you need to measure the PTT. So does that mean that only PTT will be raised in case of heparin, right?
No, both of them, because factor 10 is a part
Yeah,
of.
because the common pathway is inhibited, the factor 10, factor 2, right? These are the part of common pathway. So both the PT as well as the PTT will rise in case of heparin. Okay, but you only measure the PTT values. These are the important one in case of heparin. Okay, although both values will rise, but the PT will this PTT will rise more than the PT, so you don't measure the PT much. Okay, you only measure the PTT in case of heparin. Okay, so what are side effects? Again, the bleeding can happen. Okay, and the heparin-induced toxicity or the heparin-induced thrombocytopenia can also occur, right? Heparin can also cause the osteoporosis. Okay, and whenever you have this toxicity of the heparin, okay, for the for the immediate reversal of the steps of the heparin, you need to give the patient protamine sulfate. Okay, it will bind to the heparin and it will and it will prevent the heparin to bind to the antithrombin 3. Okay, so very important about this protamine sulfate. It can It can cause the immediate reversal of the steps. Okay. Now, apart from heparin, you also have the low molecular weight heparin, like the enoxaparin, very important. Actually, same as like the heparin, it will bind to the antithrombin 3 first, and then it will bind to the factor 10 activated. Okay. Majorly, it will only bind to the factor 10. Okay, but minorly, it can also bind to the factor 2 again. Okay. And then you have the fondapyrox, which can only bind to the factor 10 and not to the factor 2. Okay, so both heparin and the low molecular weight heparin, they have activity against the factor 2. Okay, although this low molecular weight heparin has a very low activity, but it still has the activity. But this fondapyrox, it do not have any activity against the factor 2, just the factor 10 activated. Okay, and yeah, once you give the patient these drugs, you do not need to measure the PTT values anymore, right? Very important. And these agents can be given subcutaneously, okay, without the lab monitoring of the PTT. Okay, this is an important thing. And yeah, and this low molecular weight happen, they undergoes the renal clearance, right? And the unfraction happen, which is this one, the normal happen, it undergoes the hepatic clearance, right? So this low molecular weight happen is kind of contraindicated in case of renal insufficiency. Okay, whenever you encounter a patient having a chronic kidney disease, you won't give them the heparin because it undergoes the renal clearance. Okay. So yeah, whenever you encounter a patient who is admitting to your hospital and they're undergoing any stasis, because whenever they're bedridden, okay, it will be a stasis, and you guys already know that stasis is a very common or a very important risk factor for the thrombosis, right? The
Yeah.
Werpers triad.
Yeah.
Okay. So whenever you encounter a patient who is bedridden in the hospital, you always want to give them the heparin in order to prevent this thrombosis and this embolism condition in them. Okay. Just after a surgery, you always need to give the patient this heparin. Okay, because the post-operatively you will having this hypercoagulant state. Okay, and to prevent that condition, you will give the patient heparin again. So any post-operative stage, okay, any kind of hospital admission with a prolonged stasis, okay, any kind of this deep vein thrombosis episode, okay, or the MI, you always give the patient heparin first. Okay. Then you have the heparin-induced thrombocytopenia, which is a toxicity of the heparin. What happens is the antibodies are formed against the heparin, which is bounded with the platelet factor 4. You guys remember about the about these 4 factors the platelet has?
Cash.
Apart from cash, the 4 Fs. Remember the fibrinogen, the fibronectin, platelet factor 4, and the 1 William factor, right?
Yeah. Yeah.
So the platelets also has this platelet factor 4. Heparin will bind to this platelet factor 4 and it will form a neoantigen, okay, which is kind of a new to your body. Now the IgG will develop against this neoantigen, which is heparin bounded with the platelet factor 4. And now what happens is that whenever these antibodies bind it to this complex, okay, heparin with the platelet factor 4, it will activate these platelets. Okay, and when the platelets get activated, they will form the microthrombiles. Okay, that is the first thing. And whenever your IgGs are binded to this neoantigen, because this neoantigen is present on the platelets, what's going to happen? They will opsonize these cells to the macrophages, right? And as a result, the macrophages will cause the phagocytosis of the platelets. Okay, so by the platelet activation, okay, and because of the platelet consumption, this consumption by the macrophages, what you will have is the thrombocytopenia. Okay, majorly because of the macrophagic consumption, okay, you will have a thrombocytopenia. And because the platelets are being activated now, they will form the microthrombies also. Okay, so whenever you have the activated platelets, okay, they will be destructed in the spleen, so that can cause a thrombocytopenia, which is a major cause. Minor cause also includes the platelet activation. Okay, and because of this activation of the platelets, you can also have the thrombotic episode. So a patient who is in the hospital, who is on the heparin therapy, now they are having this very severe kind of leg pain. Okay, a very severe leg pain, and and the examination shows a deep vein thrombosis. So, giving a patient heparin, and even after giving the patient heparin, they are having this deep vein thrombotic episode, which means it is heparin-induced thrombosis. Okay, is that clear?
Yeah, I have one doubt.
Yeah.
Why do we not monitor the patient when the patient is on low molecular weight heparin or fondaparinux?
Maybe because they're kind of more safer drugs than the heparin.
Okay, all right. Thank you.
And the highest risk is with the unfractioned heparin, which is a normal heparin. Although you can have this HIT with any kind of heparin. Okay, you can have the HIT with this heparin, with the low molecular weight heparin, with the fondaparinux. Okay, so any kind of heparin can causes HIT. Okay, and just the highest risk is associated with the unfractioned heparin. Okay, and we also have the HIT type 1, in which you have a very milder drop in this thrombocyte level. Okay, not a very clinically significant. Okay, usually the condition is also asymptomatic. Okay, the HIT2 is very important. Okay, in which you have a very severe drop in the platelets, and this drop, will make the platelet count less than 1 lakh. It is very important. Whenever you have this HIT, the platelet count will drop to 1 lakh. Okay, in case of this deep vein thrombosis, or you can say the DIC. Okay, in case of DIC, you will be having this consumption of the of all the platelets, right? So you will be having a low platelet count. Okay, in case of DIC, but even though after the DIC, the platelet count will still remain more than 1 lakh. Okay, only if the platelet counts are is reaching below 1 lakh, then you will suspect the HIT2 in the patient. Is that okay?
Yeah.
Generally, whenever you have a thrombosis anywhere, or you have the DIC, the platelet count will still remain above 1 lakh. Okay, only because of the HIT2, when you have a reticuloendothelial destruction of the platelets by the macrophages in the spleen, okay, then you can have this platelet count less than 1 lakh, which indicate the patient is having a HIT2, not a normal thrombotic episode. Okay, to remember these facts. Okay, any doubt on the heparin?
Uh,
Yes.
it can cause both pathway elevation,
It can cause both.
both PT and APT, increase in both PT and
Yes.
APT. How does it
Yes.
causes? How?
Because heparin is inhibiting the common path with the factor 10, the factor 2. Remember, after factor 7, and when the factor 9 is formed, right? This factor 9 and factor 7 then activate the factor 10, right? Remember the coagulation pathway?
Increase the increase. Yeah, I remember the common pathway.
Yeah. So common pathway includes a factor 10. Then factor 10 will activate the factor 2 with the help of factor 5. Factor 2 will activate the factor 1, which is the fibrinogen, right? And then the meshwork will be formed. So all these common pathway include the factor 5, the factor 10 and the factor 2, and you're inhibiting the common pathway actually with the help of heparin, right? So that's why it will increase both the PT as well as the PTT. Okay. Is that okay?
Yes, I got it. Thank you.
Any more doubt on the heparin?
No, thank you.
Now comes the warfarin. Okay, and the major action of the warfarin is on the liver. You guys studied that already. In the liver, you have this epoxide reductase enzyme, which will activate the vitamin K by reducing it. Okay, the heparin inhibit this enzyme so that the vitamin K won't be activated. Now you have the factor 2, factor 7, factor 9, factor 10, protein C and S. Okay, and the activation of these, or the maturation, I must say, not the activation, the maturation of these clotting factors requires the carboxylation of these factors. Okay, and this step also requires a vitamin K activated. Now, because the vitamin K is not available to the liver cells, as a result, the maturation of these factors, the factor 2, 7, 9, 10, and the protein CS cannot be happen, and as a result, you will get the anticoagulation effect. Okay, and you because it mainly increase the factor 7 also. Okay, the major effect of the warfarin is on the factor 7, so it will cause the prolongation in the PT. Okay, and for the PT prolongation, you will measure the INR of the patient. Remember the INR, the
Yeah.
patient's INR divided by the normal the PT of the patient, right? So this ratio will be measured, the INR, right? So this is how the warfarin actually acts. So the warfarin, it do not have any action on the blood actually. Okay, it has the action on the liver. Okay, all these clotting factors which are being synthesized by the liver, warfarin has the action on it. And as you can also see that if the clotting factors are present in the blood, okay, after the maturation from the liver, then warfarin cannot inhibit them. Okay, and because warfarin cannot inhibit them, so it dependent upon the half-life of all these factors. Only when these factors will become deficient in the blood, then only the warfarin can show its effect. Okay, because it is preventing the new synthesis of these clotting factors. So only when the previously formed clotting factors are gone, then the effects of warfarin could be start. Okay, and that's why you have to wait like for 1 or 2 weeks after giving the warfarin in order to have any effect of the warfarin. Is that okay?
Yes.
And if I take a blood sample separately, okay, and in one blood sample I will add the heparin. In another blood sample, I will add the warfarin. Can I have a raised PT or PTT in case of warfarin?
No.
In this case, no, because the warfarin has an action only on the liver, not on the blood. Okay, once the factors are formed, warfarin cannot do anything about them. Only the newly synthesizing factors can be inhibited. Okay, so for the warfarin, you mainly use it for the chronic anticoagulation. For the acute anticoagulation, you will always use the heparin. And once the patient is kind of is stabilized with the heparin, then only you will give the patient warfarin. Okay, in case of venous thromboembolism prophylaxis, in case of arrhythmias prophylaxis, you can always give the patient warfarin, because the heparin is only available in the IV dose. Okay, and the warfarin is available on the oral dose. Okay, this is also a factor why we give the patient chronic warfarin therapy, not the heparin therapy. And second is the heparin induced toxicity, for which we give the patient warfarin instead of the heparin. So heparin only for the acute use and warfarin for the chronic use. Okay. You cannot use the warfarin in case of pregnancy because it can easily cross the this placenta barrier, the blood placenta barrier, and as a result will cause harm to the baby. It is highly teratogenic. Okay, and you always follow the patient's INR or the PT values. Okay, and the rat poisoning, you guys know, it also contains the warfarin. So whenever you encounter a case of a patient who is having a history of rat poison, so Stephen will ask you what could you give to these patients, okay, as an antidote. So just remember the PCC or the fresh frozen plasma, because the rat poisoning actually contains the warfarin. And can anyone tell me how much time would it take for the rat poisoning to cause its effects in case of
The
suicide? Yeah.
half-life of the drug, half-life of the factors, more than half-life of the factors,
So how much time you're expecting?
7 to 10 days.
Exactly. These patients will always tell you that that 7 to 10 days earlier they have eaten this rat poison. Okay, and only after 7 to 10 days they can have the effect of this rat poison, not immediately. That important. Okay, so it is more important for the history of the patient. Okay, generally then in the step 1 they will mention at this point that the patient has eaten uh, or consumed this rat poison kind of 7 to 10 days earlier, and now they're presenting to your OPD or to your emergency department. Okay, so that's how you know the patient is also having the warfarin. Okay, and yeah, so now comes the adverse effects. Of course, the bleeding. Okay, It is also highly teratogenic drug. Okay, and in case of a patient having a factor, the deficiency of protein C and S, remember,
Yeah.
if you're having a patient who is in a deficiency of protein C and S already, and above that, if you give the patient warfarin, then you guys know that the shortest half-life is of the factor 7 and then the protein C and S. And because they're already deficient in these patients, above that, if you give the patient warfarin, then you're a kind of you're making the patient more prone for the thrombosis because of this transient hypercoagulable state, right? So the patient can have the skin or the tissue necrosis after giving the patient warfarin. Okay, it has very important duct-to-duct interactions also, right? The initial risk of hypercoagulation because of a protein C has a shorter half-life than the protein than the factor 2 and the factor 10. Okay, so this existing protein C will become depleted very early stage and you will have left with the hypercoagulable state, and in that case the patient can have a tissue necrosis or the skin necrosis, as you can see in this uh, figure also in picture, right? This is a skin necrosis mostly happen in case whenever the patient has having a deficiency of protein C and protein S already, right? It is because of the formation of small vessel thromboids, the microthrombites will be formed, right? Any doubt on that part?
I have one question.
Yes.
Why do we not give chronic heparin therapy? Is it because only because we have to give it subcutaneously and the patient will be less compliant?
Yeah, exactly. One thing is that, and second is a heparin-induced toxicity also, thrombocytopenia, HIT, right? So
All
HIT
right.
would be there,
Yeah, yeah,
and the IV route or the subcutaneous route is kind of very much difficult for the patient to take, and
yeah,
the warfarin is available for the oral form, right?
yeah, yeah. Okay,
So these
got it.
factors. Okay.
Thank
And
you so much.
so for the reversal of the warfarin, you can give the patient vitamin K, but the vitamin K therapy takes time, of course. For the immediate anticoagulation effect, for the immediate reversal of the anticoagulation effect, you need to give the patient fresh frozen plasma or the PCC, okay, which contains a factor 2, 7, 9, 10 protein C and protein as for the rapid correction. Is that okay?
Yes.
To prevent this condition of the skin necrosis or the organ necrosis, you always give the heparin before the warfarin, and this is known as the heparin bridging. Okay, first you give the patient heparin, and then the patient is and when the patient is kind of stabilized with the heparin, then you will give the patient warfarin because a hypercoagulation state then can never be occur. Okay, so always heparin before the warfarin. Any doubt on that part?
No, thank you.
And this heparin is now have a very severe drug-to-drug interactions. Okay, first let's talk about the dietary vitamin K in the patients who decreases the quantity of the vitamin K, because you guys know that vitamin K actually reverse the effect of warfarin. So if you're having a deficiency of vitamin K, then in that case the patient can have a toxicity of the vitamin of this warfarin very easily. Okay, their INR will increase at a very low dose of the warfarin if you're having a deficiency of vitamin K. Okay. Second thing, if you take any kind of drug who's who can disrupt the microbial flora in the GIT, like any antibiotic, and you guys already know that vitamin K is actually released from these gut bacteria, right? So in scenario, if you're having a patient who is kind of hospitalized for the pneumonia or something like any other infection, and he's taking the antibiotics, in that case, a patient can have a vitamin K deficiency, and it will make the patient very prone to develop the warfarin toxicity also, right? So whenever you give the patient any antibacterial drug, you will always lower the dose of warfarin to prevent the toxicity. Okay. Third interaction is the cytochrome P450. Any drug who is a inhibitor of cytochrome P450, okay, you always need to decrease the dose of warfarin, because in that case, you can have a toxicity of the warfarin because the warfarin is metabolized by the cytochrome P450, right? So if you do not decrease the dose of warfarin, you will have a very severely increased PT or the INR of the patient. Is that okay?
Yeah.
And generally, you will measure, you will maintain the INR at around 2.2 of the patient, right? So INR is normally 2.2. Whenever you want to give the patient warfarin, you always want to achieve this level of the INR, the 2.2. Less than 2.2 means you're having a to therapeutic level, and higher than that means you can have a toxicity of the warfarin. So make sure to know that things. Any doubt on this page?
No, thank you.
Okay, now the comparison between the heparin and the warfarin. First, at the route of administration, the heparin is available in the IV form or subcutaneous form, and the warfarin is available in the oral form. Okay, the site of action of the heparin is some blood. Remember, it can inactivate both the clot associated as well as the free floating thrombus in the vessel. Okay, of the thrombin, not a thrombus, sorry, of the thrombin in the vessel, right? So, and the action of the liver, and the action of the warfarin is on the liver, not on the blood. Okay, onset is very rapid because it can inactivate the activated factor 10 and factor 2 also. Okay, but the warfarin, it has to wait for the previously found clotting factors to kind of deplete, right? So, the effect of the warfarin will always take time. Okay, for the MOA, it will activate the antithrombin 3, which will bind to the factor 2 and the factor 10 and inhibit them. Warfarin, it inhibits epoxide reductase so that the activation of vitamin K is inhibited and the synthesis of these factors will be inhibited. Duration of action for the heparin is hours. Okay, it started acting very early and its effect also gone very early. For the heparin, for the warfarin, it has a very longer T half. Okay, so a minimal number of doses are required. Okay, so that and as a result, the compliance of the patient is very much increased with the warfarin because of very high TF, a large TF. Okay, for the agent of reversal, you will use the protamine sulfate in case of heparin, and you will use the vitamin K for the chronic reversal of the anticoagulation, and for the acute reversal, you will give the patient the fresh frozen plasma or the PCC. Okay, and you need to measure the PTT in case of heparin, and you need to measure the INR or the PT, which means the extrinsic pathway in case of warfarin. Okay, placenta cannot, the heparin cannot cross the placenta, but the warfarin can, and that's why this drug is very much teratogenic. So you want to avoid this drug in pregnancy. Is that okay?
Yeah.
Okay, now comes the factor 10A inhibitor, which means these are the drugs inhibit the factor 10 activated only. Okay, they cannot do anything about the inactivated factor, which is a normal form. They can only inactivate the activated factor 10. And these drugs are the apixaban, rivaroxaban. They have this XA in their name. Okay, they bind to the activated factor 10 and inactivated. Okay, and you can use them in the agents whenever, in the scenarios whenever you are having uh, a clot in your blood, okay, a formation of thrombus in the blood, right? So it includes the prophylaxis therapy for the deep vein thrombosis or the pulmonary embolism. You can use them for the stroke prophylaxis also. Okay, for the patients having any kind of arrhythmias, you can use these drugs. Okay, and yeah, so because these drugs are kind of inhibiting the factor 10, right? So they're promoting the conversion of the prothrombin into the thrombin. They are not inhibiting the conversion of factor 10 into the factor 10 activated. Okay, it has already done. They inhibit the factor 10 which is already activated, right? And by inhibiting that factor 10 activated, it actually, these drugs are actually inhibiting the conversion of the prothrombin into the thrombin, which means the factor 2 to factor 10 to factor 2 activated, right? So please note that fact. Okay, and whenever you have any thrombotic episode, whenever you have a formation of any uh, clot, you will use these drugs. Okay, and these drugs have a very less variability in case of any therapeutic effects, unlike the warfarin, which has many interactions. As you can see, if you have a deficiency of vitamin K or a toxicity of vitamin K, if you're using these the antibiotics, if you're using any cytochrome P450 inhibitor, then this warfarin has a many interactions with that drug. Okay, so therapeutic the variability in the therapeutic effect is very much variable in case of this warfarin, right? And but if you use these drugs, the apixaban, rivaroxaban, then you do not need to worry about these interactions. And as a result, the variability in case of a therapeutic effect is very much less in case of these drugs. Very important. Okay. And of course, just like any other anticoagulant, uh, bleeding is a risk factor. Okay. Very important. And you cannot use these drugs again in the pregnancy because they can cross the blood-brain barrier. And out on the factor 10 A inhibitors.
How do you give them?
What?
Like, you know how my heparins were IV and warfarin is oral? Is there any
Yes.
specifics for these?
Is there
Oh,
any specific?
like these are oral, right?
Yeah.
All right, thank you.
Okay. Now comes the thrombolytics, okay, which can directly dissociate the thrombus, okay, which is formed in the vessels. And you always use these drugs whenever you need the immediate anticoagulation or a very severe or a massive kind of uh, the clot formed in the vessels, right? So these drugs are known as alteplase, the retiplase, okay, streptokinase, and the tenteplase. Okay, so all of them have this name place in it. Okay, and these drugs, they actually activate what substrate? Does anyone remember?
TPA.
uh, TPA are the name of these drugs, yes, but what does these drugs do?
Plasminogen to plasmin conversion.
Yeah, exactly. They will convert the plasminogen to plasmin, and plasmin can directly act on this fibrin and will dissociate into the D dimers. Okay, so whenever you have any massive thrombotic episode, in which you require very immediate anticoagulation, okay, you cannot give the patient heparin. In that case, you need to give the patient thrombolytics. Okay, and these drugs, they will increase both the PTD as well as the PT. Okay, and they will increase the D dimer level also. Okay, and yeah, so the use in the earlier MI, whenever you encounter a patient with the MI, with the ST segment elevated MI, I must say, in that case, you can either give the patient these thrombolytics, or you can do the patient, or you can do the PCI in the patient. Although PCI is very much preferred, okay, but if the PCI is not available, then you give the patient thrombolytics. Okay, very important. In the early ischemic stroke, you can give these agents. Okay, in a very severe pulmonary embolism, you can give these drugs, or for a direct thrombolysis. Okay, very important. So whenever you have a very life-threatening kind of condition, okay, because of these clots, okay, you always want to give the patient thrombolytics in that case. Okay, the complications again includes a bleeding. Okay, if the patient is having any kind of a previous hemorrhagic episode, okay, and then the clot is formed and the vessels are sealed after that, right? So if you give the patient this thrombolytic therapy, then this the previously formed clot will be dissociated again, and the patient can have a risk of hemorrhage. Okay, especially the brain hemorrhage the patient can have, right? So these drugs are kind of contraindicated in the patients having any case of active bleeding, okay, or a history of intracranial bleeding, okay, because you need the clotting in the blood to prevent this kind of bleeding, right? So if you give the patient thrombolytics, then this clot will be dissociated and the patient can again have the hemorrhagic episode, right? So so these drugs are kind of contraindicated in a patient having any previous history of the bleeding or any active bleeding, right? And their effect could be reversed with the help of aminocaproic acid or the transaminic acid. Okay, very important. And yeah, factor corrections could be done with the cryoprecipitate, with the fast motion plasma, or with the PCC. Any doubt on the thrombolytics?
No, thank you.
So only for the life-threatening conditions you can use a thrombolytics. Okay, now then comes the ADP, and then and now we have discussed, I think, every agent. Yeah, we have discussed every anticoagulant agent. Okay, and now we will discuss the antiplatelet agent. Okay, they do not have any action on the clotting on this pathway, on the coagulation pathway. Okay, they have the effect on the platelet activation. First are the ADP receptors inhibitor. Okay, these are the P2Y12 receptor inhibitors. And remember when the ADP bind to this receptor, it will cause the translocation of the glycoprotein 2B3A. Okay, and the glycoprotein 2B3A is required to form the weak platelet plug. Okay, so these drugs, the clopidogrel, the plasogrel, okay, the ticagrelor, and the ticlopidase. Okay, these drugs can inhibit these receptors, and as a result, they will prevent the activation of the platelets. You can use these drugs in case of acute coronary syndrome. Okay, and yeah, and you can also use these drugs in the coronary stenting, because a complication of this stent placement is a formation of a clot in it. Okay, so basically it will decrease the reoccurrence of the thrombotic stroke. Okay, so you can use these agents in them. Okay, in the stent placement, you always want to give the patient these drugs in order to prevent a re-stenosis of the vessel. Is that okay?
Yes.
So, and yeah, they have no use in case of deep vein thrombosis. Once the thrombus is formed, once the clot is formed, okay, once the coagulation pathway is started, okay, then these drugs have no use. Then you only need to give the patient anticoagulants. Only when the coagulation hasn't yet started, okay, then only you can give these drugs to prevent this complication. Okay, you will always want to prevent the complication of this clot formation, right? uh, so that's why you need to give these drugs to the patient. Okay, but once the clot is formed, then these drugs have no effect. Then you need to give the patient these anticoagulants only. Any doubt on this page?
No, thank you.
Now the glycoprotein 2B3A inhibitors, which are the apixaban, aptefibatide, and the tirofiban. Okay, and you use these drugs only for the percutaneous coronary intervention (PCI) whenever you have a ST segment elevated myocardial infarction. This is a very major use of these agents. Okay, they will prevent the activation of the platelets because they inhibit these glycoprotein receptors so that the fibrinogen cannot bind to these receptors, and as a result, the platelet to platelet aggregation is inhibited. Right? Mainly use these drugs for the PCI. Complications again includes the bleeding and the thrombocytopenia. Okay, any doubt?
No, thank you.
Okay, so we have finished with the anticoagulation therapies, and now let's discuss the chemotherapy. Okay, we have discussed all the cell cycles. First, we have this G0 phase, which is a resting phase in which the cell is not dividing, it's just growing. Okay, then the cell, whenever this growth factor comes, okay, the cell will enter into the G1 phase. Okay, and from the G1 phase, they will go to the S phase, then the G2 phase, and then the M phase. M phase is the shortest phase where the actual division occurs. Okay, in the S phase, the cell will prepare itself for the G2 and the M phase, which means the replication of the DNA and the organelles will occur in the S phase. Okay, the checking of the DNA happens at these checkpoints. Okay, from G1 to S transition and from the S to G2 transition, right? And the double check repair occur in this part, the G2 phase. Okay, so all of these agents we are going to discuss. Okay, some of the agents can act on the G1 phase, some of the agents can act on the S phase, some of them can act on the G2, and some of them can act on the M phase. And some agents are also there which are non-cell cycle specific, which means they can act on either the G1 as G2 or M phase of the cycle. Okay, these are the cell cycle independent drugs. Then there are certain drugs which can only inhibit this S phase. Certain drugs can only inhibit the G2 phase. Certain drugs can only inhibit the M phase. Okay. So for the cell cycle independent drugs which do not require any stage, okay, you will give these drugs and you will get the effect. Doesn't matter in what stage the cell was. These are the platinum agents like the cisplatin, alkylating agents, okay, busulfan, the cyclophosphamide, ifosfamide, okay, and the nitrous ureas. Okay, these are the drugs which are independent of the cell cycle. Then you have certain drugs which act on the S phase. You guys know that in the S phase, I'm synthesizing my organelles, I'm synthesizing my DNA, right? So these drugs are known as the anti-metabolite drugs. They inhibit the DNA replication. Okay, and the name includes the azathioprine. Okay, and it is a prodrug of the 6-merceptopurine. You guys already know that. Okay, the cladibrin. Okay, the cedarabrin, the 5-fluorouracil. If you guys remember from the biochem lectures, from the very first lecture of the biochem, we have discussed the 5-fluorouracil, right?
Yeah.
Okay, the hydroxyurea, methotrexate. These are the drugs which inhibit the synthesis of the DNA. So they're basically acting on the S phase. Then certain drugs which inhibit the synthesis of DNA as well as the G2 phase. These are the topoisomerase inhibitor. Okay, and does anyone remember the function of topoisomerase?
To supercoil is prevented.
Yeah, to prevent the supercoiling. Okay, and you have the adipocyte, tenopocyte. Okay, and then the irinotecan, topotecan. And does anyone remember what drugs inhibit what kind of topoisomerase?
The first two inhibit topoisomerase 2, and the next two inhibit topoisomerase 1.
Yeah, and the topoisomerase 1 makes a single cut, and the topoisomerase 2 makes double cut. Okay, so whenever you give these drugs, you will have a single cut in the DNA strand. In case of these drugs, you will have the cut in both the strands of the DNA, right? So these are drugs which can inhibit both the G2 phase and the this S phase. Then you have the drug which is bleomycin. Okay, and it is kind of an antibiotic drug. Okay, and it inhibits the G2 phase of the cell cycle. Okay, then you have these drugs which can act only on the mitosis phase, because you know that in case of mitosis, I require the microtubules, right, for the movement of the chromosomes in the cell, right?
Yeah.
So whenever I give the patient microtubule inhibitors, okay, like the vincristine, vincristine, or the paclitaxel, right, these drugs can inhibit the microtubule formation, and as a result, these drugs will inhibit the M phase, right? So these drugs are specific for the M phase. Is that okay up to here?
Yes.
Okay, so let's discuss the action of certain drugs. First are the anti-metabolite drugs, okay, which inhibits the nucleotide synthesis, which are these drugs, okay. Some drugs like the 5-fluorouracil or the methotrexate, okay, they inhibit the thymidine synthesis. You guys already know that. Drugs like the 6-merceptopurine or the prodrug azathioprine, it can inhibit the de novo synthesis of the purine. And does anyone remember what is step in the synthesis of purine this drug inhibited?
PRPP aminotransferase.
Exactly, which converts a PRPP into the IMP. So this part is inhibited, right? Then you have the hydroxyurea, okay, which inhibits the enzyme ribonucleotide reductase that converts the RNA into the DNA. Remember that the DUDP to the UDP to the DUDP, right?
Yes, yes.
So this part is inhibited by the hydroxyurea. Then you have certain drugs, okay, which act on the DNA and disrupt the DNA. Okay, I'm not talking about a specific cell cycle. Okay, all of the drugs, okay, among these drugs which can act on the DNA and can directly damage it. Okay, it includes in this class, doesn't matter at what stage to do that. For like the alkylaging these agents, okay, the platinum agents, they will cross-link the DNA, and after the cross-linking of the DNA, they will damage it. Okay, in case of bleomycin, it will make the DNA strand breakage in the G2 phase, right? The dactinomycin and the doxorubicin, which are the antibacterial drugs, again, they are the chelators of the DNA. Okay, actually, they have the multiple functions. This dactinomycin, it has a multiple function. We will discuss that later. Okay, and but one of them is the DNA this DNA integrators. Okay, then you have the drugs etoposide, tenoposide. It acts on the DNA and it inhibits this enzyme, the topoisomerase. As a result, the two cuts on both the strands of the DNA will be formed. Then you have the iotican and the topotecan, which makes a single-stranded cut in the DNA. Right. So all of these agents are acting on the DNA. Okay, at any stage of the cell cycle, they can do that. In case of alkylating agent, any stage, of course. In case of bleomycin, the G2 phase. In case of dactinomycin, again, I think any stage. In case of etoposide, tenoposide, iotican, topotecan, G2 phase mainly, and the S phase also. Right. Then you have the drugs which inhibits the M phase, and these are the vincalkaloids, vinblastine, which inhibits the microtubule formation. Then you have the paclitaxel, which will cause a stability in the microtubules. As a result, it will inhibit the microtubule disassembly, the paclitaxel drug. Is that okay up to here?
Yeah.
So let's discuss all these drugs one by one. First, we have the anti-tumor antibiotics. Okay, the bleomycin drug. Okay, it has a main action on the. You need to remember the every phase of every drug. It is very important. You need to remember what drug is acting on what phase of the cell cycle. They will ask you this. They will give you the mechanism action of the drug. Okay, so they want you to first they want to know the name of the drug, and then they will go one step further, and they will ask you at what stage of the cell cycle this drug is working. So you need to know the phase of the drug also, right? So the bleomycin, it mainly acts on the G2 phase. Okay, it will cause the free radical formation in the DNA, and as a result, the DNA strands will break. So this is the action of the bleomycin in the chemotherapy, right? And you need to remember the the side effects of this bleomycin, because it can cause the pulmonary fibrosis. This is the most important one. Okay, whenever you give the patient bleomycin, the patient can have the pulmonary fibrosis as a side effect. Okay, so they will generally present you with the shortness of the breath, a prolonged history of shortness of the breath. Crackles would be there. Chest X-ray would show some kind of infiltrates. Okay, which are the fibrotic plaques of course. Okay, on the skin, these patients can also have the hyperpigmentation. These two things are important. Okay, the skin hyperpigmentation and the pulmonary fibrosis. You need to remember these two major side effects. Bone marrow suppression is very much common with every drug, of course. So a minimal this myelosuppression will be there. Doesn't matter, right? The two important ones are the pulmonary fibrosis and the skin hyperpigmentation. Okay, so you can also relate this drug with this drug, the metronidazole. Remember, because this drug also can this drug also will release the free radicals in the cell, in the bacterial cell, and as a result, the oxidation of the DNA will happen, right? And it will disrupt the DNA strands. Okay, so step one can also ask to this fact, get that what other drugs can be acting similarly to this bleomycin, and this would be the metronidazole. Okay, because this drugs can inhibit the this drug will cause the DNA strand to breakage by causing the free radical generation. Is that okay about the bleomycin?
Yes.
Then you have the dactinomycin. Okay, and yeah, it will intercalate the DNA first. Okay, and it will also prevent the RNA synthesis. Okay, it will first intercalate into the DNA, and then it will prevent the RNA synthesis. Two functions of the dactinomycin. Okay, and just like any other chemotherapeutic agent, it can cause the myelosuppression. Doesn't matter. Okay, then these are the important ones, the anthracycline antibiotics. Okay, it includes the doxorubicin and the daunorubicin. They have the multiple actions on the cancerous cells. First, just like the bleomycin, they can cause the generation of free radicals. Okay, just like the dactinomycin, they can intercalate the DNA, right? And as a result, they will cause a break in the DNA to decrease the replication of the DNA. Okay, just like your the vinca alkaloids, they can sorry, not the vinca alkaloids, I'm sorry about that. Just like a topoisomerase inhibitor, they can also inhibit the enzyme topoisomerase 2, and as a result, they will cause the DNA breakage. Okay, so multiple MOAs. One is the free radical, just like the bleomycin. Okay, the intercalation in the DNA, just like that this drug dactinomycin. Okay, and as well as the inhibition of the topoisomerase 2, just like the topoisomerase inhibitors, the etoposide and the teniposide, right? So remember these drugs. Side effects are very much important because they can cause a dilated cardiomyopathy. They will cause a fibrosis in your myocardium, and as a result, a permanent damage to the heart can occur. This effect is not reversible. Please note that it is permanent once it happens. To prevent this condition, you need to give the patient the dexamethasone. Okay, very important. You need to give the patient dexamethasone. Okay, very important. It will be an iron chelating agent. Okay, and it will promote. It will prevent the Any doubt on that? And just like any other drug, you can have the myelosuppressions and the alopecia, okay, which is common with every chemotherapeutic agent, not a very specific for that. Specific one is a dilated cardiomyopathy. Okay, any doubt on these tumor antibiotics?
What's the meaning of intercalation into the DNA?
Um, it kind of, how can I explain you this? I will type it down later. Don't worry about that. Okay,
Okay.
I will type it down for you. Okay, just wait for some time. Okay, and every chemotherapeutic agent that you give to the patient, okay, these chemotherapeutic agents, they have, this activity, they have this ability to cause another type of cancer. Although all these anti-cancer drugs, they're preventing one type of cancer, but these anti-cancer drugs can also cause another type of cancer also, like the leukemias, for example, right? So whenever you give these, any of the anti-cancer drug, okay, and after giving the therapy, the patient is presenting you with another type of cancer. Okay, so these are the complication of these anti-cancer drugs. Okay, note that fact, very important. Okay, any doubt?
Do we need to remember the clinical uses of those specific drugs?
No, you don't need to remember any specific use of the drug. You
Okay.
just need to remember the side effects and the MOA of the drug. These two parts are very important.
Okay. Okay. Thank you.
Yes. Okay, then the ionizing radiations, which is a radiotherapy, not the chemotherapy. Okay. In this case, ionizing radiations can cause the formation of free radicals. If you guys remember from the general pathology, okay, the radiations can cause the generation of free radicals, and as a result, the damage to the DNA can happen by the free radical formation, just like the bleomycin, right? And as a result, the double-stranded DNA breakage will happen. Okay, and yeah, this is a mechanism of action of the this ionizing radiations. Okay, they will generate the free radicals and they will cause the DNA damage. Okay, so because you need to put the radiations, first, whenever you give the patient radiotherapy, the radiation first need to go through the skin, right? So they will always causes the skin damage. Okay, on the acute skin damage, the patient can have this ulcerations and the blistering of the skin, just like any and with any other radiation. Okay, these patients can have the ulcerations and the blistering of the skin whenever you give the patient radiation therapy in a very acute stage. Okay, this redness of the skin can also happen. The skin peeling can also happen, right? These are all the acute therapy. Whenever you give the patient acute therapy, okay, within 90 days after giving the patient chemotherapy, these symptoms can arise, right? Because of the apoptosis of the basal cells and the epidermal cells, right? For the chronic, because you will have, you will have the healing as well as the inflammation at the same time. Okay, so you will have the fibrosis also. Okay, so in that case, you will be having this itching, ulcerations, hypopigmentations, because all of these cells which are in the melanin, they will die again. Okay, so they will cause a hypopigmentation. You will have the telangiectasias, right? You will have increase in the dermal collagen. Very important. You will have the increase in dermal collagen. You will have the high level of TGF beta. You will have the fibrosis within the skin. Okay, and you will also have the microvascular damage and the dilation, and that causes the telangiectasias in case of the chronic therapy. Okay, so step one can ask you this. They will give you a patient having some kind of a skin rash, okay, or a skin ulcer, and the previous history of the radiation therapy. They will ask you why this patient is having this kind of skin ulcer, right? So it is not because of any cancer, but because of a side effect of the radiation therapy. Okay, they want to trick you into this, but they will give you the options like the squamous cell carcinoma or the basal cell carcinoma and other things. Okay, and one of them is the radiation therapy. So you need to remember that whenever you encounter a patient having a previous history of the radiation and now some kind of ulcer on the skin, that means it is a side effect of the radiation therapy, not a new cancer. Okay,
Yeah.
so that's about the radiation therapy. Okay, and in case if you want to give the radiation therapy to the lungs, for say, then what going to happen to the lungs? What can happen to them? again the cells in the lungs will die, and that can even lead to the ARDS, right? In acute radiation therapy, ARDS can also happen in the lungs, right?
Yeah.
In case of liver, it can lead to liver failure, okay, just like that, and any other areas also. So that's about the ionizing radiations. Then comes the anti-metabolites, and all of these drugs will act on the S phase of the cell cycle. First is the azathioprine or the 6-merceptopurine, which will inhibit the conversion of PRPP into the IMP by inhibiting the enzyme PRPP aminotransferase. Okay, azathioprine is a prodrug of the 6-merceptopurine. This 6-merceptopurine is the activated form, right? These drugs will be activated by the enzyme HGPRT, okay, which is the enzyme for the Leishman syndrome, right?
Yeah.
So these drugs will be activated by the enzyme HGPRT, and they need to be inhibited by the xanthine oxidase. So in the scenario, if you give the patient xanthine oxidase inhibitors, okay, then in that case, you can have an increase in toxicity of these drugs. Is that okay?
Yes.
And what are the toxicity of these drugs? The myelosuppression, GI damage, and the liver toxicity, right? You will have the high ALT, AST, you will have this nausea, vomiting, diarrhea. You will have the myelosuppression more. So whenever you give the patient allopurinol or the febuxostat, you need to taper, you decrease the dose of these drugs, okay, to prevent the toxicity. Okay. Then you have the cladribine, and if you guys remember from the biochem lectures, the cladribine is an inhibitor of the adenosine deaminase, and as a result, the level of the adenosine will rise, and the adenosine is very lymphotoxic, you guys know. So I mainly use them for the hairy cell leukemia. Okay, very important. Yeah, and that's about the cladribine. Okay, and it is also a purine analog, because the adenosine is a purine, right? So it is a purine analog. Okay, then you have the cytarabine. Okay, and it is a pyrimidine analog. Okay, and as a result, it will inhibit the DNA replication. It will cause the DNA chain termination. Okay, and at higher concentrations, it can also inhibit the DNA polymerase also. So at low concentrations, it is inhibiting the DNA replication. At higher concentration, it is inhibiting the DNA polymerase. Okay, and it can again cause the pancytopenia by inhibiting the bone marrow, just like any other drug can cause. Nothing much special about these drugs. So any doubt on about these drugs, the cladribine and cytarabine?
No, thank you.
Just remember, the cladribine is a purine analog and the cytarabine is a pyrimidine analog. Okay. Then you have the drug which is 5-fluorouracil. Okay, and the function of this drugs is to inhibit the conversion of the DUMP into the thymidine, right? They will become the analog of this DUMP, okay, which is the 5-FDUMP they are, okay. And now the enzyme, which is thymidinate synthetase, okay, instead of binding to the normal DUMP, okay, it will bind to this 5-FDUMP instead. And whenever this drug, whenever this enzyme bind to these drugs, these drugs will inactivate the enzyme, right? And because you know that this methyl group is responsible, okay, sorry, this methyl group is required for the action of this enzyme. It will combine this methyl group on the UMP to form the thymidine, right? So basically, if you have a more level of methyl, okay, and a more level of this drug, then what can happen? More suppression of the enzyme can happen, and more effect of the drug will you will get. Okay, so in the scenarios, if I give the patient what you call is a folate supplement, right, or or the leucovorin drug, remember
Yeah.
the drug? Okay, so in that case, these drugs will generate the more CS3, okay, or the more methyl, right? And whenever I have a more methyl, I can have a more activity of this drug, because whenever more methyl is available, okay, so it will take the methyl group and it will combine the methyl group with this thymidine synthetase, and it will inactivate both of these, right? So this is very important to note, okay, that the leucovorin, it will enhance the effect of this 5-fluorouracil, okay, because the 5-fluorouracil requires a methyl and this the tetrahyd the methylene tetrahydrofolate and this thymidine synthetase in order to inactivate this enzyme, the thymidylate synthetase. Is that okay?
Yes.
Can you repeat that a different way, please?
Yes. What?
Can you say that again? I did not understand this concept of adding the methyl. How is that going to help my
Let
situation?
me annotate it. See, you have this DUMP, okay? Right? You have this DUMP. It need to be converted into the TMP, right? And it is done by the enzyme thymidylate synthetase. Is that okay? Okay.
Yes.
And to have this leucovorin, or I can say the tetrahydrofolate, the N5 N10 methylene tetrahydrofolate. Remember,
Mm-hmm.
you have the methyl tetrahydrofolate. Okay. And what does this thing do? It will donate the methyl group to this enzyme. Okay, so that this enzyme can combine this UMP and the methyl together to form the TMP. Is that okay?
And the leucovorin is acting where?
Leucovorin is actually a methyl tetrahydrofolate.
Oh, okay. So you are adding so leucovorin is basically adding or allowing more methyls from the MHTR.
Exactly. What happens if you give the patient 5-fluorouracil? It will act as a 5-FDUMP, okay, which is kind of an analog to the DUMP. Okay, but whenever it binds to this enzyme, the thymidylate synthetase, it will inactivate it. And because the function of this enzyme is to combine this methyl group with this DUMP, so if the more methyl is available, more inactivation of this enzyme can happen. Right?
Yeah.
If I give the patient leucovorin, I'm giving the patient methylene tetrahydrofolate, right? Which means more methyl is now available for this drug to act. If more methyl is available, then more inactivation of this enzyme will occur.
Okay, so the point of this is to turn off my thymidylate synthase.
Turn off or turn on?
Okay, see, my problem is I understand how the methyl group is added. I understand that FDUMP is basically an analog for DUMP, and that
Yes.
DUMP and the MTHR, they come together with the thymidylate synthase and they make DTMP. That
Yeah.
part I understand. I don't,
Yes.
okay, and then I don't understand the purpose of this cycle though. Are you saying that you want to, by giving leucovorin, or sorry, the thymidylate synthase, like I don't understand how this is, like I thought this is all pushing the system forward. Adding leucovorin is pushing the system forward. Leucovorin is also
If I add this leucovorin, I'm giving the patient this time, this thing, okay, this tetrahydrofolate, right?
Mm-hmm.
If I give the patient leucovorin, I'm giving the patient methylene tetrahydrofolate, right? In
Yeah.
that case, more methyl will be available for this enzyme and for this drug. Is that okay?
Yes.
Because in the active, because in the presence of this methylene tetrahydrofolate, my enzyme can work only when
Mm-hmm.
this is available,
Yes.
right? And when this methylene group is available, my enzyme will get activate, and instead of taking the normal DUMP, my enzyme will take this 5-FDUMP.
Okay.
So if I give the patient more methyl, then more enzyme will get activate, and instead of taking the DUMP, more enzyme will take the 5-FDUMP and will get inactivated.
Okay, so this is gonna prevent you from creating
Exactly. I'm inhibiting my enzyme by giving the drug 5-fluorouracil, and if the methyl group is available, okay, if the methylene tetrahydrofolate is available, then I can have a more action of this drug.
Okay, so you
Okay.
are making more of the pyrimidines, but these are bad pyrimidines that your cell cannot use.
Exactly. I'm inhibiting my enzyme ultimately.
Okay, I'm sorry, thank you.
Yeah, don't worry about that. Okay, and please remember, step 1 won't give you this name, the 5-fluorouracil. They will try to trick you and they will give you this name instead, capecitabine. Okay, so please remember the 5-fluorouracil also goes by the name capecitabine. Okay, And then you have the drug, which is the methotrexate, which inhibits the dihydrofolate reductase, okay, which is an enzyme converting the dihydrofolate into the tetrahydrofolate, right? And as a result, the methylene tetrahydrofolate won't be available to the cell, and as a result, the enzyme will be inhibited, so that you won't convert the DUMP into the thymidine. Is that okay?
Yes.
And if you give the patient methylene tetrahydrofolate, then you can easily bypass this step of converting the dihydrofolate into the tetrahydrofolate, right? Is that okay?
Why so?
If I'm giving the patient already methylene tetrahydrofolate, then why I require
Yeah,
this
yeah, yeah.
step, right? I'm
Right, right.
bypassing this step already. So if I give the patient leucovorin, then I can overcome the toxic effect of the methotrexates. Is that okay?
Yeah, yeah.
While giving the leucovorin to a patient on this 5-flow uracil therapy, I'm making the condition even much more worse. Okay, I'm activating more of this drug. I'm inactivating more of the enzyme. Is that okay?
Yeah.
Okay, good. So yeah, the use of the methotrexates, you can use them for the autoimmune conditions like the rheumatoid arthritis, like the psoriasis, inflammatory bowel diseases, vasculitis. You can use them for the cancers like the leukemias, lymphomas, and other cancers also. Side effects include the hepatotoxicity. They will damage your liver because in the liver you have this rapidly dividing cells which can get damaged by the methotrexate. You will have the high ALT, AST with the right upper quadrant pain and the hepatomegaly. These cells can also damage your lungs and can cause the pulmonary fibrosis there. So you will have a difficulty breathing. You will have this infiltrates in the X-ray, okay, which are the fibrotic plaques. You will have this crackle sounds, which are the fine crackles, right? So these are all the hints for the pulmonary fibrosis, and the patient will have a chronic history of this shortness of the breath in that case, right? They can also cause the oral ulcers, okay, because the GI tract, it contains the stem cells which can get damaged by the methotrexate, so you can have a oral ulcers also. You can have a diarrhea because of that, right? And these drugs are so much teratogenic, okay, because they are kind of competing with the folate in your body, right? The tetrahydrofolate and dihydrofolate. And as a result, because of the deficiency of folate, the patient can also have the neural tube defects. Okay, so a folate supplement is required whenever you give the patient methotrexate. Okay, and these drugs are also nephrotoxic. They can cause a high level of creatinine. They can cause the oliguria. Okay, they can also cause the flank pain whenever you give the patient methotrexate. Is that okay?
Yeah.
So yeah, that's all about the toxicity of the methotrexate. So remember, they can cause damage everywhere in the body. The GI damage would be there. Okay, the lungs damage would be there. Liver damage would be there. Kidney damage would be there, right? And yeah, so effects can be reversible with the help of leucovorin, which is a folinic acid that will instantly give you tetrahydrofolate or the methylene tetrahydrofolate. So you don't need the enzyme dihydrofolate reductase to work now. Okay. So all of the rapidly dividing cells will be susceptible to the methotrexate. And of course, you can have a bone marrow suppression also. So pancytopenia is also a side effect of the methotrexate. Any doubt on this page?
No, thank you.
Yeah, thank you.
Okay. Just give me a second. Yeah. So you have now the alkylating agents. Okay, and this includes the busulfone, cyclophosphamide, ifosfamide, nitrosoureas, the procarbazole. Okay, so first let's discuss the busulfone, which causes the cross-linking of the DNA. Okay, and by causing the cross-linking, they can directly damage the DNA. Okay, and the side effects, just like the bleomycin, remember, it can cause a pulmonary fibrosis and the hyperpigmentation, right? So busulfan also can cause the pulmonary fibrosis and the hyperpigmentation. Okay, so please remember bleomycin and the busulfan both goes by the name B. Okay, and they both can cause the pulmonary fibrosis and the hyperpigmentation. Is that okay?
Yeah.
Then you have the drug which is a cyclophosphamide or the ifosfamide. They can again just like any other alkylating agents. These drugs can also cause the cross-linking of the DNA, right? And as a result, they will be useful for the tumor, of course. They can cause a very important side effects like the SIADH. Remember from the endocrine lectures we have discussed?
Yeah,
The
yeah.
cyclophosphamide and one more drug, remember, which can cause SIADH.
Demeclocycline.
SIADH.
Anti-epileptic medicines.
Yeah,
like
what
carbamazepine.
anti-epileptic yeah, carbamazepine, very important. Cyclophosphamide and carbamazepine are the two most important drugs which can cause the SIADH. Remember that. Okay, Fanconi syndrome can also occur, right? And what is a Fanconi syndrome? Remember? No, you haven't studied that. Right?
Proximal tuberculosis.
Yeah, you will study Fanconi syndrome later. Okay, in which you're having a loss of every substrate, I think, from the kidneys, right?
Yeah.
So loss of every
Yeah.
protein, every calcium, sodium, potassium, everything, right? So this is a Fanconi syndrome, which can happen because of the cyclophosphamide, right? Hemorrhagic cystitis is again a complication of the. These two are very important. The hemorrhagic cystitis and the bladder cancer. Remember, I told you all these agents are actually treating one type of cancer, but can cause another type of cancers, right? The cyclophosphamide can cause a bladder cancer. So remember, it has an effect only the bladder, not the kidney. Okay, don't misconfuse this bladder with the kidney. Okay, you cannot have this acute kidney injury with the cyclophosphamide, but you have a bladder injury with the cyclophosphamide. So they can cause the hemorrhagic cystitis as well as the bladder cancer. So how can a hemorrhagic cystitis present you with? Because it is an inflammation of the bladder. Okay, you can have a UTI like symptoms. Okay, like the urgency, frequency, burning pain would be there. So if you encounter a drug, if you encounter a patient who is having a history of UTI after giving the drug, cyclophosphamide, so just know that it is not a real UTI, but but it is actually a side effect of the cyclophosphamide. Okay, very important. You can prevent this condition by giving the patient masna. Okay, and of course the hydration will be very important. So hydration and the masna for the cyclophosphamide and the ifosfamide. Then you have the drug nitrosoureas, and the important one is the lomustine. Okay, this one. They again, just like any other alkylating agent, can cause the cross-linking of the DNA. Okay, and they are because they can easily cross the blood-brain barrier. Okay, these drugs are so much useful for the brain tumors. So whenever you heard about the brain tumor, you always think about the lomustine for the therapy, right? And because the major action of these drugs is in the brain, so they can cause the convulsions, dizziness, ataxia to the patient, right? So the CNS drugs having the CNS side effects, having the CNS activity. So okay, everything CNS for the lomustine. Then you have the procarbazine, and the only thing you need to remember for the procarbazine is that it is a weak MAO inhibitor, and as a result, it can cause the cheese reaction. Is that okay?
Yeah.
So the only thing you need to remember of the procarbazine is the cheese reaction they can cause. And yeah, so any doubt on the alkylating agents?
No, thank you.
Okay. And a DNA cross-linking is like a formation of this bond between the two nucleotides. Okay, a covalent bonds. Generally, you have this a weak hydrogen bond in between the two strands of the DNA, right?
Yeah.
But in this case, in the cross-linking, you will be having this covalent bond between the two nucleotides of the DNA, right? And the covalent bonds is not like I draw this. Generally, have the DNA, okay, and at the same level, you have this nucleotide here. You have this nucleotide here. Similarly, you have this nucleotide here and this one here. So a weak hydrogen bond will form between these two and between these two, right?
Yes.
in the nucleotides which are opposite to each other. But in case of a cross-linking, you have one nucleotide here, one here, similarly one here, one here, one here. So this covalent bond, instead of hydrogen bond, can form either in between the opposite nucleotides, okay, or this covalent bond can form in between the other nucleotides also, like this. This is a cross-linking of the DNA. Okay, are we good?
So basically, cross-linking does not mean that one DNA is getting one double helix is getting attached to another double helix.
No. You have a single double helix. See, you
Okay.
have a continuous DNA segment, right? It is not our DNA is kind of fragmented.
Yeah,
Our
yeah.
DNA is single thing, right?
Yeah.
So it is just a formation of this covalent bond in between in multiple nucleotides.
Okay, I got it. Thank you.
Okay, then you have the microtubule inhibitors. Okay, and because the microtubules are required for the movement of chromosomes at the time of M phase, if the microtubules are not there, the chromosomes won't move, and the cell will be stopped in the M phase. You have the drugs, the paclitaxel, okay, and like other taxanes, they become they will make this microtubules hyper stabilize, and as a result, okay, the mitotic spindle they cannot be broken, okay, which is required for the anaphase. Remember, in case of anaphase, you will be having a separation of the two cells, right? For that, you need to break the microtubules in between the two cells, right? If these microtubules do not break, then as a result, the anaphase cannot be occur, okay, and the cell will stuck in the metaphase only, right? Because after the metaphase, you have this anaphase. So if the anaphase is not there, the cell will stuck in the metaphase only, okay. And because these drugs are kind of stabilizing the microtubules very so much, okay, and the microtubules are also used for the transmission of neurons, or sorry, for the nerves, for the neurotransmitters, right? So these drugs can also cause the neuropathy. So a neuropathy, myelosuppression, hypersensitivity are the side effects of these drugs. Then you have the vincristine and vinblastin, okay, which actually inhibits the formation of microtubules. Remember how these microtubules are formed?
Alpha and beta tubulins.
Yeah, heterodimers of the alpha and beta tubulin. Okay, they will be polymerized to form the microtubules. And these drugs inhibit this process. So as a result, the microtubules formation won't occur. And as a result, whole M phase is inhibited, right? Because you require the formation of microtubules to start the M phase. Okay, so the side effect time, the vincristine, it has mainly the effect on the neurons, and it can cause a neurotoxicity. Okay, it inhibit the transmission of the nerve impulses because the neurotransmitters are always transferred through these microtubules. Okay, so you have this neuropathy, neurotoxicity, right? You will have this areflexia, you will have the peripheral neuritis, constipation could be there, right? For the vinblastin, you have a main side effect, which is a bone marrow suppression only. So for the vinblastin, which causes a blast in the bone marrow, it will suppress the bone marrow, and the vincristine, it can cause the the neuropathy or the neurotoxicity. Is that okay?
Yeah.
I think we should take a short break here,
Okay. Yeah.
and we will continue again. Yeah, so we have discussed up to the microtubule inhibitors, right, which will disrupt the formation of the microtubules, or they will hyperstabilize the microtubules, right? And as a result, they will inhibit the M phase of the cell cycle. Now these agents, which are the platinum containing agents, okay, at what part of cell cycle they will affect?
All phases.
At all phases, okay. They will cross-link the DNA again, just like my alkylating agents, okay. And clinical use for a testicular, bladder, ovarian, lung carcinomas, you don't need to remember at all, okay. You need to remember the adverse effects. See, for cyclophosphamide, we have discussed they can cause the bladder cancer or the hemorrhagic cystitis, right? They have the major effect on the bladder for side effects, right? For cisplatin, carboplatin, and these other platins, okay, they have the effect on the kidneys, not the urinary bladders. They can cause the where they can cause the acute tubular necrosis. Okay, they can cause an acute kidney injury. Okay, so they will cause an increased rise in the creatinine levels, increased rise in the BUN. But if you give the patient cyclophosphamide, then the BUN and creatinine will be normal because this drug, the cyclophosphamide, has no side effect on the kidneys, right? But the drugs which contain the platinums, they have the effect on the kidney as they can cause a kidney damage. Very important. They can cause a Fanconi syndrome in the kidney also. Okay, and they can also cause a peripheral neuropathy. They can cause the ototoxicity also, and you need to prevent the nephrotoxicity by giving the patient amifostin. See, Masna for cyclophosphamide and amifostin for the cisplatin carboplatin. Is that okay?
Yes.
Very important. Then you have the drug etoposide and the tinoposide, okay, which inhibits the topoisomerase 2, and as a result, they will increase the DNA degradation. Because the function of the topoisomerase is to prevent the supercoiling, and they does that by making a single-stranded or either a double-stranded cut on the DNA. The topoisomerase 2 will make a double-stranded cut in the DNA, right? So what does this drug do? They will let the topoisomerase cut the DNA, but it won't. But they won't let that this enzyme to repair the DNA again. As a result, you will have the double-stranded DNA cuts if you give the patient etoposide and the tinoposide, right? And the side effects again includes the myelosuppression and the alopecia. And you use these drugs mainly for the small cell lung cancer, if you want to remember small cell lung cancers. Okay. Then you have the this irinotecan and the topotecan, okay, which inhibits the topoisomerase 1, okay, and they will ultimately cause a single stranded DNA break, right? Very important. And again, small cell lung cancer, you can use these drugs for, and the side effects include the severe myelosuppression and the diarrhea, just like any other what drug can do. Then you have the drug which is the hydroxyurea, and the function of the hydroxyurea is to inhibit the enzyme ribonucleotide reductase. And you guys already know that the function of the ribonucleotide reductase is to convert the
Deoxyribose to ribose sugar.
exactly deoxyribose to ribose sugar. You're saying opposite.
Right.
Ribose to deoxyribose sugar, right?
Yeah.
And it is mainly the UDP which is converted to the DUDP, right? If I open the biochem again, just give me a second, so we can relate them again. Just give me a second. See, for the pyridine synthesis, first we have the glutamine CO2, which will form the carbamyl phosphate that will convert it into the orotic acid. Orotic acid, with the help of the enzyme GMP synthase, will be converting into the UMP. UMP will be converting into the UDP. Then this UDP will convert it into the DUDP with the help of enzyme ribonucleotide reductase. DUDP will be converting into the again DUMP, and this DUMP will be forming the DTMP, right? And it is by the thymidylate synthetase. This enzyme could be inhibited by the 5-fluorouracil or the capecitabine, and we know how by combining the methyl group with this enzyme. Okay, the 5-fluorouracil inhibit this enzyme, right? And the methotrexate will work on here. It will inhibit the conversion of the dihydrofolate into the tetrahydrofolate. If you give the patient leucovorin, then you're directly giving them this methylene tetrahydrofolate bypassing this enzyme, right? So I can overcome the toxicity of this methotrexate by giving the patient leucovorin. But if I give the patient leucovorin, then I will give him more methylene tetrahydrofolate, and as a result, more of the enzyme will be inhibited, right? So let's go back to the hydroxyurea again, which inhibits some ribonucleotide reductase, and as a result, just give me a second. Yes. So the hydroxyurea again, which is inhibiting the ribonucleotide reductase, and as a result, the synthesis of the this DUDP will be inhibited, right? And it can cause a megaloblastic anemia. Why?
Because of prevention of the formation of nucleotides.
Yeah,
And
exactly. Yeah. So because I'm preventing the formation of my nucleotides, I cannot have the DNA maturation. I cannot have the nuclear maturation of the cell, and what I can get is the megaloblastic anemia. You use these drugs for the sickle cell anemia. If you guys remember, these drugs can increase the fetal hemoglobin, right? So these drugs are kind of very much protective for the sickle cell anemia. But these drugs are actually preventing sickle cell anemia. Okay, and after preventing sickle cell anemia, they can also cause the megaloblastic anemia. So they are preventing one type of anemia but causing another type of anemia, right? So yeah, you need to give the patient this thymidine for that, right, to prevent this condition. Then you have the drug which is a bevacizumab, and if you guys remember, MAP for the antibodies, ZU for the humanized, right, and VA for the vessels. So these are the monoclonal humanized antibodies against the vascular endothelial growth factors, which inhibits the angiogenesis. Okay, and because you guys know that every tumor requires the formation of the blood vessels, right? So they are a kind of very much active against all of the solid tumors, because all of the tumors require the new blood vessel formation, angiogenesis, right? And these antibodies are inhibiting it, right? Apart from the tumors, important disease in which you can use a bevacizumab is the wet age-related macular degeneration, in which you have the formation of new vessels. You can also use these agents for the diabetic retinopathy, okay, a proliferative type or a non-proliferative, both could be used. Okay, so a diabetic retinopathy is the first use. Okay, age-related macular degeneration or the ARMD, WET, you can use these agents, and of course solid tumors. Okay, side effects include the hemorrhage because they inhibit the blood vessel formation. Blood vessels can even get weak. They can cause a hemorrhage. They can cause a blood clot, and they can impair the wound healing, because you know the angiogenesis is required in what phase of wound healing?
granulation for granulation tissue.
Yeah, the granulation tissue formation, right? You require the formation of the blood vessels there, right? So they impair the wound healings also. So please remember, they are against the VEGF, and the special use is the VET ARMD as well as the diabetic retinopathy. Then again, you have the NIB, okay, erlotinib, which is again a tyrosine kinase receptor inhibitor. You use them mainly for the non-small cell lung cancer. Side effects again include the rash and the diarrhea, right? Then again, you have the drugs which are against the EGFR, the epithelial growth factor receptors, okay, which are for the epithelial tumors, okay. Cetuximab, okay, you don't need to remember these antibodies, sorry. Okay, I've never encountered any question on them, so you can just skip them. But just know that because they are the inhibitor of the EGFR. This is an important thing. Okay, the only thing I need to remember, they are the antibodies against the EGFR. Any doubt on this page?
No, thank you.
Then you have the other tyrosine kinase receptor inhibitors, which are the imatinib mostly. Okay, and you use this imatinib mainly for the CML. Okay, and also as a chronic myeloid leukemia. Okay, you know that in case of chronic myeloid leukemia, you will be having a fusion of BCR and the ABL, and as a result, the hyperactivation of this tyrosine kinase will occur, right? And it will cause the growth of the cells. So you use this inhibitors of the tyrosine kinase, the imatinib, for the treatment of the CML. Okay, and yeah, that is the only use of these drugs. Then you have the rituximab. Okay, and you guys already know that this rituximab is a monoclonal antibody against the CD20. So I can use them for most of the B cell neoplasms, the non-Hodgkin's lymphoma. I can use them for the chronic uh, lymphoid leukemia, okay, lymphocytic type leukemia, the CLL. Okay, I can use them for the rheumatoid arthritis. I can use them for the TTP, okay, which is the thrombotic thrombocytic purpura. And does anyone remember what is the pathology behind it?
You can't break up Adam's T13.
Yeah, Adam TS30. Okay, remember that. And AIHA also, right? Autoimmune hemolytic anemia. You can use this. Why in the autoimmune hemolytic anemia? Rituximab.
Does it prevent the autoimmune, whatever the
Yeah, because in case
attack?
of AIHA, I'm having the antibodies against my RBCs, right? So, and these antibodies are ultimately going to form from the lymphocytes, from the B lymphocytes. So, if I give the patient rituximab, then I can inhibit those lymphocytes which are sensitized against my RBCs, right? So, these drugs can also be useful for the AIHA. So, TTP, AIHA, very important use. These two must be remembered. And for the tumors purpose, I can use them for the chronic lymphocytic leukemia and non-Hodgkin's lymphoma. Okay, and they can increase the risk of progressive multifocal leukodystrophy. And does anyone remember the pathogen behind it?
JC virus.
The JC virus. Because of the myelosuppression, I can have the activation of the JC virus, and that JC virus can cause the progressive multifocal leukoencephalopathy. Then you have the drug which is the bortezomib, and you have studied that drug already when we were discussing about this, the proteasome thing, right? These are the boron containing drugs that inhibits the proteasome, right? And as a result, all of the toxins, all of the toxic proteins and the pro-apoptotic proteins will start accumulating inside the cells, right? And as a result, the apoptosis of the cell will occur, right? Because the toxic proteins or the malformed proteins, right, and the pro-apoptotic proteins, all of these proteins will be start accumulating inside the cell that will cause the apoptosis. You use the bortezomib drug mostly for the multiple myeloma. Okay, although you can use the for the mantle cell lymphoma also, but this multiple myeloma is a very important part where you use this drug. They can cause the activation of the herpes zoster virus because of the uh, suppression of the immunity, of course, right? Then you have the drug tamoxifen and the raloxifene. Okay, and these are the selective estrogen receptor modulator. Okay, these are the receptor modulators. At some tissues, they will be estrogen receptor positive. At some tissues, they would be estrogen receptor negative. Okay, depending upon the location of the receptors, they could be agonist and they could be antagonist. Okay, and mostly use these drugs, especially the tamoxifen for the breast cancer, okay, and raloxifene for the osteoporosis. So in the step one, if they ask you about a patient who is having a breast cancer, what drug you must prescribe? You must prescribe them the tamoxifen. And if you encounter a patient who is having a osteoporosis, and if the step one asks you what drug should be given, it would be the raloxifene. Although you can use the raloxifene also for the breast cancer, but we uses the tamoxifen mainly for the breast cancer. Okay, so remember the drug uses the tamoxifen for the breast cancer and the raloxifene for the osteoporosis. Okay, tamoxifen has this agonist activity at the uterus, okay, and as well as on the endometrium, okay, and as well as on the bone. They have this agonist activity, right? And so that's why tamoxifen can also increase the risk of endometrial cancer. While the raloxifene, it has the agonist activity only on the bone, but the antagonist activity on both the breast and as well as the endometrium, right? So with the raloxifene, there is no increased risk of this endometrial carcinoma, right? So I can easily give these drugs for the osteoporosis because I know that these drugs, they won't increase my risk of endometrial carcinoma, right? But the tamoxifen, because it is increasing the risk of endometrial carcinoma, I cannot prescribe these agents for the osteoporosis, right? Because I'm putting my patient on a risk of cancer if I give these drugs for the osteoporosis. Okay, side effects of the drug, it includes both of the drugs can cause the deep vein thrombosis, they can cause the pulmonary embolism, they can cause the hot flashes because these drugs are kind of inhibitory on the this endometrium, and they will cause the cycle dysregulation. So they can cause the hot flashes, they can cause the deep vein thrombosis, they can cause the pulmonary embolism. Is that okay?
Yeah.
Just give me a second. Okay.
I have a question.
Yeah, to ask.
Tamoxifen does have some activity in bones.
Yes.
So I'm
Is it?
asking if it if it has some activity on bones
Yeah, of
also?
course. It has a agonist activity on the bone.
Okay. And I
See,
have
in the
another.
bone, see,
Yeah, yeah,
actually in the bone, you have the osteoblast cells, right? And the
yeah,
osteoblast
right.
cells, they can either form the rank receptor, the rank ligand, okay, or they can inhibit the rank ligand by releasing one protein
Osteoporosis,
name,
OPG.
yeah, OPG, right? So what does these drugs do? They will stimulate the estrogen receptors, okay, and the function of the estrogen is to release the OG in this.
OPG,
Yeah,
osteoprotogranin.
yeah. Sorry, the OPG, right? So if you
Yeah,
give
right.
these drugs to the patient, then I'm having more OPG than the rank ligand. And as a result, this OPG will bind to the rank ligand, inhibit the activation of the osteoclast. And that's how these drugs are having a agonist activity on the bone. They will promote the bone growth, right?
Right. So I just have to look if the patient has any risk factor for endometrial disease
Yeah,
like this,
exactly.
cannot prescribe tamoxifen, right?
Exactly. If the patient is having any hyperestrogenism like the PCOS or the other
Yeah.
OCPUs, okay, or it could be a patient with African descent because they have a high risk of this endometrial cancer. So you cannot prescribe these patients these drugs, okay?
Right. Got it.
You need to use
Another
for that.
question I have.
Yes. Yes.
Bortezomib is only used in multiple myeloma because no, sorry,
Yes.
bortezomib is used for multiple myeloma, and
Yes.
actually I'm not getting it like in mantle cell lymphoma. We are also using it.
Yeah, we are also using the bortezomib in the mantle cell
Sorry,
lymphoma
sorry, sorry.
also.
So this is not the question I wanted to ask. Actually, I wanted to ask about rituximab. Like it is against CD20, which is in B cells, right? But
Yes.
but we are not using it specifically in B cell tumors,
Yeah, because you do not have the CD20 for the T cells, right?
right?
So they're inactive against the T cells.
Okay,
They're
okay.
only active against the B cells. So that's why only on the B cell for lymphomas or the leukemias, I can use these drugs. Okay.
Okay, okay.
And
Right.
another
Thank you.
important
Thank you.
point that the tamoxifen and yeah, okay, thank you so much. And another important point that this drug, the tamoxifen and the raloxifene, they are dependent upon the cytochrome P450 for their activation, right? They will be activated by the cytochrome P450. So the drugs which inhibits the this cytochrome P450, they actually can cause a treatment failure of the tamoxifen and the raloxifene. Is that okay?
Yeah.
Oh, fine. Yeah, yeah. Thank
Remember
you.
this. Yeah, remember this fact also. Very important. And then you have the drug, the trastuzumab, okay, which is the receptor antibody against the HER2 new receptor, okay, or the ERB-B2. Remember about the ERB-B1 or the HER1? Where does it found? We have discussed about the ERB-B2 and the ERB-B1, right? In a general pathology. Where does this ERB-B1 found? In the lung cancers, right? No?
Yeah, we have discussed that. Thank you
See, okay,
for letting me.
RB1 for the lung adenocarcinoma and RB2 for the breast cancers, right? So these are the antibodies against the HER2 new receptors or the RB2 receptors, which is a tyrosine kinase receptor, of course. Okay, and you use them mainly for the breast cancer, and you can also use them for the gastric cancer, because you know that you have whenever you have a mutation in the HER2 receptors, you can have either the breast cancer or you can have the gastric cancer, right? So I can use this drug, the trastuzumab, for the breast cancer and the gastric cancer. Do not forget the mutations; these are very important. Okay, you need to memorize them every day, okay, so that you can get what mutations are causing what kind of tumors. Very important to note, okay. Okay, the trastuzumab can cause the dilated cardiomyopathy just like my doxorubicin. Okay, but in case of that drug, I was having the fibrosis in my myocardium, right? And this condition was kind of irreversible, right? But in case of trastuzumab, the DCM I'm having, this condition is properly reversible, okay? And because it is just a decrease in the myocardial contractility, it is a mechanical loss of the function of the myocardium, right? The structure of a myocardium is absolutely normal, no fibrosis is there, right? I'm just having a mechanical loss of the contractility, and as a result, if I stop the drug, I can reverse back the symptoms. But in case of the doxorubicin, okay, in that case, I'm having a fibrosis in my myocardium, and as a result, that condition was irreversible. This is a huge difference between the DCM of the trastuzumab and the DCM of the doxorubicin. Is that okay?
Yeah.
Don't forget that point also. Then these drugs which have the RAF in their name, okay, RAF or the BRAF, okay, and that's why they are the inhibitors of the BRAF, okay. And you guys know what tumors are associated with the BRAF?
Melanoma, hairy cell leukemia, small cell lung cancer.
Small cell lung cancer. Oh, I'm not sure about
No,
small cell lung cancer.
Colorectal
Uh,
cancer, hairy cell.
Not the colorectal cancer. No, it was the KRAS and the colorectal cancer, not the BRAF.
non-Hodgkin lymphoma.
Non-Hodgkin's lymphoma. I think it was there in the non-Hodgkin's lymphoma.
Anaplastic
But
thyroid? Or sorry,
you
Papillary
guys are
carcinoma
forgetting.
of
Papillary
thyroid.
thyroid.
Yeah,
Okay.
exactly. Papillary thyroid carcinoma. Okay. So melanoma, papillary thyroid carcinoma, hair cell leukemia. Yeah, non-Hodgkin's lymphoma also. Okay. But it is not the major one in the non-Hodgkin's lymphoma. Okay. So just remember three cancers, okay, mostly, which are papillary thyroid carcinoma, melanoma, and the hair cell
Papillary
leukemia.
thyroid.
Hairy cell leukemia.
Okay, for the BRAF inhibition. Okay, very important. So these drugs which have the name, which have this BRAF in their name or the RAF in their name, they are the inhibitors of this BRAF. Okay, and they can prevent the metastatic melanoma. They can also be used for the hair cell leukemia and for this papillary thyroid carcinoma also, but mainly we use them for the metastatic melanoma. Okay, then comes a raspberry case, okay, which is not not a chemotherapeutic agent, but we use this drug for the tumor lysis syndrome. And does anyone remember what iron with these regulations I can get with the tumor lysis syndrome?
Potassium phosphate.
Potassium.
Calcium level high or low?
Low.
Low.
Low, because this phosphate bind to the calcium, right? And I would also have the high level of
Uric
Potassium.
acid.
it was not the sorry, it was a phosphate which binds to the calcium, right? Not the
Yes.
potassium, it was a phosphate that binds to the calcium. You will have the high level of potassium, you will have the high level of phosphate, you will have low level of this calcium and a high level of uric acid, right? And to prevent the uric acid stones, I need to give the patient rasparicase, okay, which is a recombinant uricase that will convert my uric acid into more stabilized form or a more soluble form, which is the allantoin, right? So that it could be easily excreted from my body. Okay, so I prevent the tumor lysis syndrome because of that. Okay, so now the key chemotoxicities, okay, and you can remember this whole of the diagram for the ease. So first of all, you will have the cisplatin and the carboplatin drugs, okay, or the platinum containing agents. You guys know that these agents are the ototoxic and nephrotoxic, right? So CC here for the kidneys, these two C's are for the ototoxicity. You have the vincristine and the vinblastin, and the vincristine can cause the peripheral neuropathy, right? So V here representing the peripheral neuropathy. You have the cyclophosphamide, which acts on the bladder, can cause the bladder cancer and the hemorrhagic cystitis. So cyclophosphamide for the bladder cancer and the hemorrhagic cystitis. You have the doxorubicin and the trastuzumab, which can cause the dilated cardiomyopathy. So D and T for the heart. And then you have the bleomycin and the busulfan for the lungs. You guys know that these can cause the pulmonary fibrosis. And what other drug can cause a pulmonary fibrosis?
Methotrexate, amiodarone,
That,
and
yeah,
nitrofurantoin.
yeah. These drugs can also cause the pulmonary fibrosis, right? So do remember the name of these agents. You can remember this whole diagram. Okay, it is a very good thing, good one. Okay, and yeah, while other drugs, all of them can have the bone marrow suppression. So bone marrow suppression, the pancytopenia, these are all the non-specific side effects of every drug. Okay, and you guys know that if I give the patient the chemotherapeutic agents, what is the most important WBC which will become deficient?
Neutrophils.
Neutrophils. I will always have the neutropenia first whenever I give the patient these agents, the chemotherapeutic agents, right? So I can have the invasive infections from my fungus, like the aspergillus, like the candida. If I have the HIV, then I will lose my lymphocytes. In that case, I cannot have the invasive infections. I can have the superficial infections, right? Like superficial infections like the oral thrush and other things, right? And so yeah, these are the chemotherapy, the side effects of the chemotherapy. First is the mucositis, which is very common with every chemotherapeutic agents. They all can cause the ulcers in the mouth. They all can cause the diarrhea, right? Most of them can cause the neutropenia. Okay, and so that all of the commensal agents. So yeah, Stephen will also ask you this fact that whenever you give the patient chemotherapy, what were the first agents or the first pathogens that will cause the infection in your body? So these are all the commensal pathogens. All of the pathogens which are commensal in my body, like the candida, which is a natural habitat, uh, unnatural flora of my mouth. Okay, the candida and like other agents also. Okay, they will can cause the infection in my body whenever I have the neutropenia. So the first infection is from the commensal pathogens. Okay, then I can have any other acquired pathogen infection from outside, right? But the first infection is always indigenous type. It is always from the inside bacteria in my body already. And because you do not have any neutrophils, right? So you do not have the major signs and symptoms of the inflammation. You just have a mild fever and chills. Okay, so whenever you encounter a patient with a history of chemotherapy and now he's having the fever and chills, okay, that means the patient is having an infection with any of the indigenous flora of the body, right? All of the commensal pathogens can cause it, right? And the cell-mediated immunity, these are the side effects of the AIDS and the immunosuppression. Remember the immunosuppressive therapies for the this organ transplant. Yes, organ transplant, immunosuppressive therapies.
Yes.
Steroids.
Yeah, steroids, of course. They all can cause the cell-mediated immunity inhibition, which are the lymphocytes mainly, right? And whenever I have the inhibition of the lymphocytes or the lymphopenia, in that case, I can have the most common infections from the opportunistic bacteria or the pathogens, and from the disactivation infections. And in between these two, the reactivation infections are most common. So with the loss of lymphocytes, I will have the reactivation infections, then the opportunistic infections. With the neutrophils, I will have the commensal pathogen infections. Is that okay?
Yeah.
And does anyone can tell me the name of the immunosuppressive agents which inhibit the calcium in urine?
Cyclosporin,
And
tacrolimus,
yes. And what is the mTOR inhibitor?
Sirolimus.
sirolimus.
Yes. Good. Remember these names, very important. Okay, their function and the FK binding protein. What two agents can bind to FK binding protein? Sirolimus and tacrolimus, right? Tacrolimus can bind to the first it will bind to the FK binding protein, and then after binding to the FK binding protein, that this drug then can bind to the calcineurin. Is that okay? And then it will inhibit the translocation, the translation of the interleukin 2, right?
Yeah, yeah.
So remember, and similarly, the sirolimus first bind to the FK binding protein, then it can bind to the mTOR so that it will inhibit the effects of the interleukin 2. Okay, the signaling of the interleukin 2 will be inhibited, right? So these agents can first cause the reactivation infections, and then they will cause the opportunistic infections. In case of neutropenia, I will first have the infections from the commensal pathogens, which are the natural habitant in my body, right? They will overgrow, they will cause the infections. They can cause the invasive infections like the candida. Okay. So yeah, that's everything about it. Any doubt?
No, thank you.
Okay, so we are done with the hemong completely. We have discussed the embryology, the anatomy, the pathology, and then the pharmacology. Now, you guys want to study the MSK, or you want to do it, just call the day off? It's up to you.
We can study musculoskeletal.
Yeah, we should continue.
Okay, so we will continue with the MSK. Just give me a second. Sorry, I forgot to record. Yeah. So for supraspinatus, it causes the abduction of the arm, right? And it is the most common muscle which is compressed or which is injured in any rotator cuff injury. So whenever you encounter a patient who is having a rotator cuff injury and they cannot move their arms, right? And if step one do not give you any specific hint for a muscle, so you will always consider it an injury of the supraspinatus. Okay, and for that you need to do the empty can test. Okay, let me describe this empty can test. First, you will ask the patient to cause the abduction at the 90-degree. Okay, then the 30% flexion would be there, and then you ask the patient to point the thumb on the floor. First, you will abduct their humerus to 90-degree, right? And then you will ask the patient to point the thumb to the floor. If the pain occurs, that means it is a supraspinatus muscle injury. Okay. Generally, patient will have a shoulder pain. Okay, they will have a very localized tender on the palpation. Okay, and they will always have the weakness of the muscle function, like the this abduction. Okay, and that tendon will be compressed or kind of impinged between the head of humerus and the acromion process. Okay, this is the rotator cuff syndrome, which is most commonly occurred because of the supraspinatus muscle injury. Then you have the infraspinatus. Okay, and the function of this muscle is to cause the external rotation mainly. Very important. The infraspinatus, which can cause the external, as you can see the location of the muscle, if this muscle contract, it will cause the external rotation of the humerus, right? Like if this muscle contract this way, then it will cause the external rotation of my humerus like that. Then you have the teres minor. Okay, and the teres minor is the lowest one, as you can see here, this one. Whenever the muscle contract, it can cause the external rotation as well as the adduction of my arm, right? So adduction and the external rotation is for the teres minor. Then you have the subscapularis, okay, which causes the adduction again and the internal rotation. As you can see, whenever this muscle contracts, it will cause the internal rotation of my humerus as well as the adduction of my humerus this way, right? The supraspinatus and the infraspinatus, these are supplied by the suprascapular nerves, which originate from the brachial plexus. You have the teres minor supplied by the axillary nerve. Okay, and you have the subscapularis supplied by the upper and lower subscapular nerves. Okay, and they are all from the C5 to C6. Okay, and in case if you are having a damage of the infraspinatus, right, then I cannot cause the external rotation of my arm. In that case, the hypertrophy of my teres minor will occur. Okay, to assist in this external rotation more, right? And similarly, if I have a damage to my teres minor, okay, then the hypertrophy of my subscapularis and the hypertrophy of my infraspinatus will occur. The hypertrophy of the infraspinatus will cause the external rotation, and the hypertrophy of subscapularis will cause the the adduction of the arm. Is that okay?
Yeah.
So step one can give you a scenario of a patient who is having a damage to any of these muscles, and they will ask you what other muscles can go into the hypertrophy to maintain the function, right? So you need to know what other muscles have the similar functions, like the teres minor and the subscapularis. They both can cause the adduction. teres minus and this infraspinatus, they both can cause the external rotation, right? So in a scenario, if any of the muscles get damaged, the others will get hypertrophied. Okay.
Yeah.
Good. And just give me a second again. Okay, now let's discuss the function of other muscles in the arm abduction. Okay, they all will elevate the arm, they all can cause the abduction of the arm. So from 0 to 15 degrees, you require the supraspinatus muscle. Okay, so the first muscle which assists in the arm abduction is the supraspinatus, and it is supplied by the suprascapular nerve. Then up to the 100 degree, from 15 degree, it is a deltoid muscles, and they are supplied by the axillary nerve, the same nerve which is supplying your the teres minor, right? Then you have the trapezius muscle which assists in more than 90 degree, and similarly the serratus anterior which is assisting in abduction of the arm at more than 90 degree. This muscle, the trapezius, is supplied by the accessory nerve, okay, which is a branch of cranial nerve 11, okay. And you have this the muscles serratus anterior, it is supplied by the long thoracic nerve of Bell. Okay, we will discuss that later in the brachial plexus again. So in scenarios, if you're having a damage to a trapezius, or either you're having a damage of the serratus anterior, in both cases you cannot abduct your arm more than a horizontal position, okay, more than a 90 degree, right? So how you can differentiate between the damage of the trapezius and the damage of the serratus anterior? In case of a damage to the trapezius, I will be having the shoulder drop, okay, because the trapezius muscle is present like there, okay. Sorry, like that. Okay, the trapezius muscle will be like there, okay. It will go upward like that. So in a scenarios, if I get damage of my this muscle, the trapezius muscle, I will be having the shoulder drop, right? Very important. And that means I am having a damage of my accessory nerve. In case if I'm having a damage to my long thoracic nerve of Bell, in that case, I will be having a paralysis of the serratus anterior. I will be having no shoulder elevation above 90 degree or 100 degree. Apart from that, I will also get the winging of the scapula. So if you encounter a patient who is having a winging of the scapula, okay, and plus they cannot lift their shoulder more than 90 degree or 100 degree, that means it is a damage of serratus anterior. If you're encountering a patient who is having a shoulder drop along with the loss of abduction more than 90 degree, that means it is a trapezius muscle damage. Is that okay?
Yeah.
So do know how to differentiate the damage between the two nerves. Any doubt on this page?
No, thank you.
Thank you.
Okay, then you need to know about the upper extremity nerve. And before we discuss that, we need to discuss about the brachial plexus. Okay. So brachial plexus actually controls the contraction of every nerve in your upper limb. Okay. Similarly, you also have a plexus in the for the lower limb, which is known as the lumbar plexus, okay, which controls the movement of your lower limbs, right? So for the upper limbs, you have the brachial plexus. For the lower limbs, you are having the lumbar plexus, right? This brachial plexus arises from the C5, C6, C7, C8, and T5 nerve roots, okay? And the C5 and C6 first combine to form the upper trunk, okay? C7 goes like that and it will form the middle trunk. The C8 and T1 will combine to form the lower trunk. Then the division of these trunks happen into the anterior and the posterior, okay. So this upper trunk will be divided into the anterior and the posterior part. Similarly, this middle trunk, anterior, posterior, and similarly the lower trunk into the anterior and posterior, and you call them the divisions, okay. The posterior division of the upper limb and the posterior division of the lower limb, right, they both combine to form this part, and of course the posterior part of the middle trunk also, they will combine to form the posterior part, okay. The anterior division of this middle trunk, okay, as well as the upper trunk, they will combine to form the lateral cords, okay. And the anterior division of this lower limb will go like that and will form the medial cord. So medial cord is formed only by the lower this trunk, okay. The posterior cord is formed by the posterior division of the upper, middle, and lower trunk, right? And the lateral cord is formed by the uh, by the combination of anterior division of the upper and the middle limb, this trunk, right? Now, smaller branches will arise from these cords. From the posterior cord, you will have the axillary nerve, which supplies your teres minor and supplies your deltoids, right? You have the radial nerve, okay, which supplies on the medial side of this your forearm, right? And then you have the combination, further the branches from the lateral and the medial cords, they will combine to form the median nerve, okay? And the median nerves, they mainly supply your flexors, sorry, the radial supply the extensors, not the middle side of the forearm, okay? The radial nerve supplies the extensors, okay, and the median nerve supplies the flexors, okay? The branches from the medial cord, okay, from medially, it will form the ulnar nerve, and that's why the ulnar nerve runs medially in your hand, okay, and it will supply the medial structures of the forearm and the hand, right? And then we have the musculocutaneous nerve, okay, which forms by the branching of the lateral cord, okay. And now you can also imagine what what nerve roots can be forming the musculoskeletal, the median, and the ulnar one, right? For example, if I say about the axillary nerve, can you guys imagine what nerve roots are forming my axillary nerve? See, it is very easy. So, see, you have the C5 and C6, which will combine to form the upper this trunk, and this upper trunk will give its branches to form the axillary nerve, right? And because you guys know that the axillary nerve is supplying the upper part of my shoulder only, right? So it is only from the upper roots, which are from the C5 and C6. Okay. Similarly, you have the musculocutaneous nerve, which is supplying on my arms only. Okay, so these nerve are originating from the C5, C6, and C7, which supplies only the upper part of my arm, right? Then you have the radial nerve, and you guys know that the radial nerve supplies all the way from shoulder to hand. That means it must contain all the nerve branch, these roots, which means C5, C6, C7, C8, C9. All of them will take part in the formation of radial nerve, because this radial nerve supplies all the way from shoulder to the hand. Then you have the median nerve, okay, which supplies again all the way from your arm to the hand, right? So this median nerve again, the all the C5 to T1, they all will form the median nerve. They all will take part in the formation of median nerve. You have the ulnar nerve, which supplies mostly your forearm and the hand, right? And that's why it is formed by the distal roots, which are mostly the C8 and T1, right?
Yeah.
So if you just go from proximal to distal, you can easily imagine what nerve roots will be supplying. Okay, the nerve roots which are on the upper side, they will be supplying the proximal structures, and the nerve roots which are distal side, like the T1, they will be supplying by distal structures like the hands. Okay, so let's go back again and discuss every nerve one by one. So first, and we will go from from proximal to distal type. Okay, so for the proximally, first you will have the axillary nerve, which is originated from the C5 to C6. Okay, this nerve will supplying your uh, the teres minor and as well as your deltoids, right? In the causes of injury of this nerve includes a surgical neck fracture of the humerus, okay, and the anterior dislocation of the humerus, because this nerve actually runs in anterior of your this shoulder, right? So whenever you have an anterior dislocation of the humerus or any kind of surgical neck fracture of the humerus, then you can have the axillary nerve damage. And if I draw the diagram, this is your humerus, this is a surgical neck, okay, and there your axillary nerve actually runs from here, okay. So in case if you're having a damage to the this part, the surgical neck, then you can have a directly the loss of the function of this axillary nerve. Similarly, if I get the anterior dislocation of my humerus, right, then I can also get a damage of this axillary nerve, right? And whenever this nerve get damaged, I will get the flattening of the deltoids. I will have the loss of abduction of my arm, because supraspinatus muscle will be working. So up to the 15 degree, it would be normal. But after 15 degree, I need the deltoids right? So after 15 degrees, I cannot abduct my arm. I will have the loss of sensations over the shoulders, or you can say the deltoids or the lateral arm. So shoulders and the lateral arm, it will be supplied by the axillary nerves. Any doubt?
No, thank you.
Then you have the musculocutaneous, which supplies my arm part, right? It is formed by the C5 to C7 only. Whenever I have a upper trunk compression, which means this part, whenever I compress my upper trunk, as you can see, because it's MSK, this musculocutaneous nerve, it is originating mainly from the upper trunk, the C5, C6, and the C7. If I somehow get the damage of this upper trunk, then I can get the damage of this musculocutaneous nerve also, right? So the damage of this nerve, you will be mostly seen in case of this Erb's palsy. Okay, because in most commonly, it is because of the Erb's palsy, you can get the upper trunk compression and you can get the musculocutaneous nerve damage, right? And this nerve supplies your biceps muscle, which are the muscles in the arm, of course, which are involved in the flexion. So you will lose the flexion, you will lose the biceps reflex. And please note the C5 and C6 is responsible for the biceps reflex. We will discuss that later. And I will also tell you mnemonic how to remember these reflexes. Okay. You will have the weak forearm flexion. Okay. And as well as a supination. Very important. This musculocutaneous nerve, it is also involved in the supination, right? If you damage this nerve, you will get the loss of supination also. And does anyone know what is supination?
Like turning the hand as palm faces the sky.
Yeah, good. Whenever the palm faces the sky, this is a supination, and whenever the palm faces the ground, this is the pronation. Okay, very important. So, yeah, that about my musculocutaneous nerve. It supplies the anterior compartment of my arm, and the anterior compartment of my arm is responsible for the flexion. So, whenever I get the damage, I will get the loss of flexion because the biceps are now lost. I will lose the supination, and it is done by the if you want to know about the muscle, it is the biceps brachii muscle, okay, which causes supination, and it is also supplied by the musculocutaneous. For the sensations, for the sensory loss, I will have the loss of sensations over the lateral forearm. See, the lateral arm, sensations of the lateral arm is supplied by the axillary nerve, and the sensations of the lateral forearm is supplied by the musculocutaneous nerve. Any doubt on that?
No, thank you.
Then you have the radial nerve, okay, which supplying the all the structures from my arm to the hand, right? It supplying mostly the posterior compartment of my this forearm and arm. Okay, it supplies the posterior compartment which is responsible for the extension of my arm as well as the forearm. So whenever I get a damage of my radial nerve, I will lose the extension of my this arm and the forearm and the hand, right? This nerve, because as you can see, it is run in a very most medial location. Okay, so whenever I get the compression of the axilla, okay, for example, due to the crutches or maybe due to sleeping over the chair with arm over the chair, right, I can get a damage of this radial nerve. This radial nerve also passes through the shaft of the humerus, right? If I draw the diagram, this nerve passes like that. Okay, like that. That's how this nerve crosses the humerus. In case if you get a fracture of the shaft of the humerus, if this shaft got fractured, then and you can know if the fracture happened at this location, happened at this location, or happened at this location or this location. In all the locations, if I'm damaging my shaft of the humerus, then I can damage the radial nerve, right? So again, if I get the fracture of shaft of humerus, I can get the damage of the radial nerve, right? And yeah, with the repetitive pronation and the supination, for example, the use of screwdriver, I can also get the damage of this radial nerve. And in that case, you will only get the finger drop. No sensory loss. We will discuss that later. Don't worry. You will only get the finger drop in that case. So because of the compression at the axilla, right, I will get the wrist drop. Okay, I will get the loss of elbow, wrist, and the finger extension, right? I will decrease the grip of my hand, because some amount of extension at the hand is required for the full grip, right? So I will lose the grip strength. I will also lose the sensations over the posterior arm and the forearm and the dorsum of the hand, because this nerve actually going all the way posterior part only, the posterior compartment, right? So I will get the loss of sensations on the posterior compartment of my arm, forearm, and hand, right? I will also get the loss of extension at the elbow. I will get the loss of extension at the wrist. I will get the loss of extension at the finger, right? And if the damage happens after the axilla, okay, and before the elbow, then I will get the sparing of the elbow, which means my elbow extension would be absolutely normal if I get the fracture of shaft of humerus. As soon as my this radial nerve exits the axilla, if I get damage anywhere in that pathway, then I will spare my elbow extension. My elbow will be absolutely normal because the branches will be given immediately after the axilla, right? So in the case, if I'm having a fracture of the shaft of humerus, in that case, my axilla, in that case, my elbow will be absolutely normal. Is that okay?
Yeah.
Okay, now after the arm, okay, when the radial nerve reaches the forearm, okay, it will be divided into the two branches. One is the superficial branch and second is the deep branch. Superficial branch supplies the most superficial structures, which are your skin, right? So the superficial branch is actually a sensory nerve. It will take the sensory information from the posterior side of my forearm and the posterior side of my hand. And this deep branch, it passes through the muscle, which are the supinator muscle. Okay. After passing through the supinator muscle, this nerve will be divided into the posterior interosseous nerve. Okay, it will divide into the posterior interosseous nerve, right? And whenever I do the repeated pronation and supination, because the supinator muscle is involved in the supination process, right, I can damage my radial nerve here in the supination muscle. And as a result, the posterior interosseous muscle is now lost. Okay, and in that case, because already my triceps reflex, the nerves for the wrist extension and for the triceps will be given off very early, so I can have a normal triceps reflex. That means the elbow extension, it would be normal. The wrist extension, it would be normal, because the branch for the wrist is already given before this muscle. All I can have is the damage of the posterior interosseous nerve, which supplies the extension of my fingers. Okay, so if I get a damage from the this repetitive supination pronation movements, like using a screwdriver, in that case I can only get the loss of this innervation to the fingers, right? My wrist will be absolutely normal, my elbow would be absolutely normal, just the paralysis at my fingers happen. I cannot extend my fingers, so I will get the fingers drop. No sensory loss happen, because the sensory nerves are already given before that. Okay, the nerve to my wrist is already given before the supination muscle, right? So damage can never happen to this muscle. Only damage can happen is to the posterior interosseous nerve, which is supplying my fingers. Is that okay?
That's
Yeah.
good. Can you point to where the supination or supinator muscle is on the diagram? Around which area?
Where? Please repeat it again. So I didn't understand.
Okay, supinator muscle, right? It's
Yeah.
where do you know about where on the diagram it would be?
On which diagram?
Just like any diagram of the hand, like there's two diagrams here.
Oh, supination muscle is here.
Okay, so would a laceration at that point also cause the same thing?
Where? Laceration at?
Yeah, no, a laceration at that point would also create the same difficulty,
Yeah,
right?
of course. If we have a deep laceration, yeah. If we have a deep laceration, it can also damage my nerve, right? In the deep
Yeah.
lacerations, I can get a damage of my radial nerve again.
Okay, thank you.
Okay. Yeah. So that's about my radial nerve. And in case of a supracondylar fracture also, very important. See, I know you guys have heard about that whenever I have a supracondylar fracture, then I can damage my median nerve. And what does that mean by that? If I draw the humerus, and at the end, the humerus will be like that, right? Okay. And these are the condyles, and this is the supracondylar part. If I get a damage here, then I can damage my median nerve. Yes, that's what God has heard, right? Please respond.
Yes.
Yeah.
Superior's
But
median and
that's not entirely true. In the supracondylar fracture, I can either have the damage of median nerve or I can have a damage of radial nerve. See, what happens is in the medial part, if this side is medial and this side is lateral, in the medial part, I will having this median nerve running. Okay. In the lateral part, I'm having this radial nerve running. So if I get a supracondylar fracture, which is here, okay, and somehow this humerus, the upper part, which is the proximal part of the humerus, is shifted right side or the lateral side, right? In that case, I will be having a damage to my radial nerve. If this humerus part, which is the proximal part, if it's shifted on the medial side here, then I can have a damage to the median nerve. So it depends where the proximal part of my humerus is shifting, medial side or lateral side. If it is shifting medial side, then the radial nerve will get damaged. In the lateral, and the medial side, I will be having a medial nerve damage. Okay, if I didn't mention that point, so you can mention that. Only if I had said that a supracondylar fracture can cause the damage to the median nerve, but that's not entirely true. A supracondylar fracture can also have a damage to the radial nerve also, right? And if I get a supracondylar fracture, then can I have the loss of elbow extension?
No.
See my elbow. See my elbow is here, right? This part is my elbow. If I get a damage of my nerve here before the elbow, can I have a loss of elbow extension?
No, because the nerve is given before.
head extension, though.
Yeah, the nerve has already been given just after the axilla, right? So the elbow will be absolutely normal. I just get the loss of extension of my wrist and the loss of extension of my fingers. And when I get damage of the nerve after the supinator muscle, in that case, the nerve to my wrist has already been given. So wrist will be normal and I will just get the finger extension. Okay, so you just need to know at what locations the nerve has been damaged. In the axilla, loss of extension of all these three locations, elbow, wrist, and finger. In case of after the axilla, okay, the elbow will be spared, and I will get the loss of extension of the wrist and finger. After supinator muscle, I will just get the loss of extension of the fingers. Wrist and elbow will be spared. Is that okay?
Yes.
So that's everything about the radial nerve. Then comes the median nerve. Just like my radial nerve, it is also supplied by all the roots C1 to C5 to T1. Okay, and the median nerve, it supplies both my forearm and the hand. Okay, it supplies the anterior compartment of my forearm, right, which is responsible for the flexion of my hand completely, right? So the damage of the median nerve can happen because of the supracondylar fracture. We have discussed how. Okay, the damage can also happen because of the carpal tunnel syndrome and the wrist laceration. If you have any wrist laceration, then you can have a damage to the median nerve because it passes through the wrist. Okay, just after the carpal tunnel syndrome. Okay, if any kind of this impingement of my nerve occurs there, then you can have a carpal tunnel syndrome also, right? So two locations where my nerve got damaged. One is at the supracondylar location, and second is at the carpal tunnel. Okay, if I have a supracondylar fracture, then I have a this proximal nerve lesion. Okay, if I have a carpal tunnel syndrome, then I will have a loss of the finger flexion will be preserved in that case. It's just a loss of sensations over my thumb or the thenar eminence will occur. Okay, and the thumb will be lost mostly. We will discuss that later. Don't worry about that. Okay, and this brachial artery. Okay, it also runs in a very close association with the median nerve. Okay, so in the scenarios where I'm having a damage to my median nerve, I can also damage my brachial artery. And then you have a deep brachial artery also, right? And the deep brachial artery run very close to the radial nerve. So whenever a step one asks you about the radial nerve damage, and they will ask you what artery could be damaged along with it, that means it would be the deep brachial artery. And when they talk about the brachial artery, that means the median nerve damage. Okay.
Yeah.
Is that okay? Yeah. So if you have a damage of the median nerve, then you can have a loss of wrist flexion, right? And why not the this elbow flexion?
Because biceps controls it, and biceps is supplied by musculocutaneous.
Yes, exactly. So only the wrist flexion will be lost, and then the flexion of the lateral fingers. Okay, and that even includes the thumb. Okay, so thumb and the lateral, your second and the third finger. Okay, the loss of flexion of these fingers will happen, right? And the lumbricals and index of the middle fingers, they also be lost. So ultimately, you're losing your finger flexions and you're losing the thumb opposition. Okay, and what does the function of lumbricals is? Does anyone know?
Abduction of fingers?
Adduction, lumbricals.
Abduction,
No,
right? Back in. Oh,
not
whoops.
the abduction.
Extension?
Anyone want to try? Where? At what joints? You have this metacarpopharyngeal, then the PIP, then the DIP, right? At what joints extension?
Uh,
Try.
distal? Oh, sorry. Not the
Wrist
dis. No.
or
More.
distal?
Yeah.
See, lumbricals can cause the flexion at the MCP, which is the metacarpopharyngeal joint, and cause the extension at the DIP and the PIP. So it will make your fingers like this. If I want to draw, if this is your metacarpals and here your phalanges started, so they will cause a flexion at the metacarpopharyngeal joint, and they will cause the extension of the PIP and the DIP. Is that okay? So that's how your fingers look whenever you use the lumbricals. Okay.
Can you explain that again, please?
Function of lumbricals is to cause the flexion at the metacarpopharyngeal joint. Okay. Do that. Make the flexion at your metacarpopharyngeal joint and extend your DIP and the PIP. See what you get?
Okay, so you're making like a right angle. That's what.
Exactly. That's what the lumbricals do. They will cause the extension at the proximal interpharyngeal joint and the distal interpharyngeal joint, and they will cause the flexion at the metacarpopharyngeal joint. Is that okay?
Yeah, thank you.
This is a function of lumbricals. So if I lost my median nerve, then I will be having a loss of my lumbricals function. In that case, I cannot extend my DIP and PIP, and I cannot flex my MCP, right?
Yeah.
What I can get is a flexion at the PIP and the DIP, and I will get the extension at my MCP. I will get this kind of thing, finger, right? This kind of fingers I will get.
Yeah.
Okay. And I think FA has shown it. You guys just give me a second. Yeah. This kind of thing I get if I get a median nerve damage. As you can see, my PIP and DIP is not extending, they will flexed, and my MCP is not flexing, it will get extend, right? This is a median claw I will get because of damage to my lumbricals. Is that okay?
Yes.
So very important to know what the function of lumbricals is. Okay, so lateral lumbricals are involved for the median nerve, they will get damaged and they will get the this claw of the this median nerve, right? And you will also have the loss of sensations over the thenar eminence, which is the lateral eminence in your hand, right near the thumb. That you will get the thenar eminence, loss of sensations. Okay, and also on the dorsal and the palmar aspect of the lateral 3.5 fingers. Okay, this is it. As you can see here, this is a palm of your hand, right? And this is a median nerve area. Okay, the thenar eminence is here. I zoom in. This is a thenar eminence supplying by the median nerve. Okay, your thumb will be supplied by the median nerve. Okay, and the second finger, third finger, and the half of this part. So 3.5 fingers on the palmar side supplied by the median nerve. On the dorsal side, again, the second, third, and the half. This is also supplied by the median nerve. Is that okay? For sensory function of the median nerve.
Yeah.
Yeah. Okay. So that's about the median nerve. It will be damaged by the supracondylar fracture. It will be damaged by the carpal tunnel, right? And uh, this nerve supplying your anterior compartment of the forearm and the anterior compartment of the anterior part of my hand. So the flexion at my wrist is lost and the flexion of my fingers is lost, right? And the lumbricals function are also lost. Okay. Then comes your ulnar nerve, okay, which is supplying the distal part of your forearm and hand. Okay, and that's why it only contains the distal nerve roots, right? Like the C8 to T1. Okay, it got damaged by the medial epicondyle fracture. Okay, the epicondyles of the humerus, if they got fractured, then you get the damage of the ulnar nerve, right? And you can also get a damage by the fracture of hook of hamate. You will study that later. You have the hamate bone, and if that hamate bone get fractured, in that case you can have the ulnar nerve damage also. Okay, in case of Guillaume's canal, okay, uh, and because of this fracture, you will have the compression of this nerve in the Guillaume's canal, like same as the case of the median nerve. Okay, if I get the compression of the nerve in the carpal tunnel, right? Similarly, I can get the compression of the ulnar nerve in the Guillaume's canal, right? Which is done by the fracture of hook of hamate, right? And yeah, so what I will get is the ulnar claw, because the medial lumbricals are supplied by the ulnar nerve. If this nerve get damaged, then I can get the ulnar claw, right? I will get the radial deviation of the wrist upon flexion. See, you have the median nerve which is causing the abduction at the wrist. You have this ulnar nerve which is causing the adduction at the wrist. If I get the damage of the ulnar nerve, then my median nerve will cause the abduction of the wrist, right? Which means the radial deviation of my wrist. Is that okay?
Yes.
Wait, I don't get what that means.
See,
Like,
you have the wrist.
Yeah.
Yeah. See, you have the wrist. Okay, like that.
Mhm.
I zoom in. This is your wrist part. Okay.
Yeah.
You have the median nerve, which is causing the lateral deviation of it. Just give me
Okay.
a second. Which is the abduction, right? Away from the body. You're having this ulnar nerve, which is causing the adduction at the wrist. Okay.
Okay. And this is
If
done
I
at supination,
at the
right?
flexion mainly, right? If I get the damage of my ulnar nerve, in that case, if I try to flex my wrist, the wrist will move outwards or away from my body, which means the abduction.
This is with my ulnar nerve damage.
Yeah, this is for the ulnar nerve damage. Okay, the
Okay.
median nerve will become will
Is
be
the
kind of
the median is the only working
overtaken. Yeah,
do
yeah,
abduction.
exactly. Yeah, it
Okay.
will take the function and it will overcome the ulnar nerve in that case, right? So you will get what is the you will get the
Abduction.
radial deviation. You will get the radial deviation, also known as the abduction upon the flexion. Is that okay now?
Yeah, thank you.
And the flexion in the wrist, for the flexion of the wrist, both the median nerve as well as the ulnar nerve are involved, right? So whenever you have a loss of any, either the median nerve damage or the ulnar nerve damage, you can have a loss of flexion at the wrist. Okay. So as you can see, both the median nerve and the ulnar nerve, they have both same function. But the only difference is that the median nerve is supplying more lateral structures and the ulnar nerve supplying more medial structures. They both can cause the wrist flexion. They both can cause the finger flexion. They both can cause the activation of lumbricals. But the only difference is the location. Median nerve is kind of more lateral, and this ulnar nerve is more medial. Is that okay?
Yeah, yeah.
Okay, and one important thing, one other function of the ulnar nerve is the interossei muscle, which are involved in the adduction and abduction of your fingers. So if you get a damage of the ulnar nerve, then the adduction and abduction of your fingers are also lost. Okay, and you will have the loss of function of the medial two lumbricals. Okay, the lateral two supplied by the median nerve and the medial two supplied by the ulnar nerve. You will get a damage of these also. And again, you will have that a loss of sensations over the medial aspect of your hand, which is the 1.5 fingers, anteriorly as well as posteriorly, as you can see. Is that okay?
Yes.
Then you have the recurrent branch of median nerve, which is the most distal branch, supplying by the C5 and T1. It is run in your palm in a very superficial location. So whenever you have any superficial laceration of the palm, you can have a damage of your recurrent branch of the median nerve. In that case, you will get the ape hand. We will discuss what the ape hand later, but you will get the ape hand because of loss of thenar muscle group. Okay, the thenar muscle group is completely lost. Okay, that means the function of your thumb is now lost. A position, abduction, flexion of the thumb is lost. Okay, but the sensory supply is already given very early, and as a result, the sensory loss won't be there, and normal senses will be present. Is that okay?
Yes.
So this is all about the your forearm and the arm and the hand. Okay. And yeah, these are the regions which are supplied by different nerve. Like for the axillary, it will be supplying your the uh, the lateral part of the arm. Okay, the musculocutaneous nerve supplying the lateral part of the forearm, right? The median nerve supplying the medial part of the forearm and the and the lateral palm, little part of your hand. Ulnar nerve supplying the medial side of your hand, right? And the radial nerve supplying the posterior side of your hand completely. And then you have one more nerve which we forgot to discuss is the medial brachial cutaneous nerve and the intercostobrachial nerve. This nerve is very important. The intercostobrachial nerve, it sometimes get damaged while doing the axillary nerve dissection. Axillary lymph node dissection for the breast cancer, right? For the breast cancer surgery, you have to remove the axillary lymph nodes. While doing so, you can damage the intercostobrachial nerve. And just know that this intercostobrachial nerve is a purely sensory nerve. It do not have any motor innervation. Okay, so what will happen? You will get a very small area of sensory loss at the medial side of your arm. Okay, step one can ask you this. Uh, it would be a patient having undergoing a surgery of the breast cancer and the removal of the axillary lymph nodes, and somehow she is having a loss of the sensations over the medial side of the hand. So they will ask you what nerve will be damaged. It would be the intercostobrachial nerve, right?
Yes.
Okay. And one more thing about these two nerves, the median and the ulnar nerve, because the median nerve supplying the thenar eminence and the ulnar nerve supplying the hypothenar eminence, right? Hypothenar eminence is basically an eminence on the medial side of your hand, and the thenar is on the lateral side. So whenever you have a median nerve damage or the paralysis, in that case, I will be having an atrophy at the thenar eminence. In case of ulnar nerve, I will be having an atrophy at the hypothenar eminence. Is that okay?
Yeah.
So we have discussed all the nerves of my upper extremity. Any doubts so far on this page?
No, thank you.
Then let's discuss what happens if you damage your trunks or other areas in this brachial pathway, right? First will be the upper trunk compression. Okay, if you get the upper trunk compression, generally it happens during the time of delivery. Okay, while delivering the fetus, if we kind of stretch the neck too much, right? So it can damage the lateral part. Okay, as you can see, this upper part or the lateral part is more superficial than the lower or the deep part. Okay, so while delivering the fetus, the iatrogenic damage to this upper part can happen, and as a result, the C5 and C6 nerve roots and all the nerves which are being supplied by the C5 and C6 will be damaged, which means the symptoms will involve only the upper part of my this arm, right, the shoulder part. So what I will have is the damage of the deltoids. I will have a damage of my supraspinatus. I will have a damage of my infraspinatus and the biceps brachii. right? Because of a damage to my axillary nerve as well as the musculocutaneous, because you know that axillary and musculocutaneous are majorly supplied by the C5 and C6. Now, because of loss of my axillary nerve, I will be losing my deltoids and supraspinatus. What I will have is a loss of abduction of my arm. Because of loss of infraspinatus, I will be having a loss of the lateral rotation. That means my hand will be internally rotated, as like that. As you can see, this hand is internally rotated. Okay, because of the biceps brachii is involved in the supination. Sorry, involved in the flexion and the supination. The loss of this muscle will cause the extension of my arm as well as the pronation of my arm, like that. Okay, and this condition is known as the waiter's step. It's looking like a waiter's step. Okay, so this is what known as the Orb's palsy because of a compression of my upper trunk. In the adults, any kind of trauma to the nerve directly can happen, right? And it can lead to the Orb's palsy again. Any doubt on it?
No, thank you.
Then you have the Klumpke's paralysis, in which you're having a damage at the lower trunk. See, if I talk about the arm, sorry, if I talk about my axilla, these are my shoulders, right? Okay, this is the axilla. As you can see, this is the upper trunk, and the length of the upper trunk is very much more than the lower trunk, right? This is the lower trunk. Okay, the length of the upper trunk is more than the lower trunk. In case if I forcefully or suddenly abduct my arm, like in this direction, okay, then what will happen? This part, the lower trunk will become too much stressed. Okay, the tension will increase and this nerve even get damaged. Is that okay?
Yes.
So in a very rapid upward kind of abduction of my arm, I can damage the lower trunk of my brachial plexus. Okay. For example, while drilling the BB, while drilling the fetus, if if we use the hands or the arms of the fetus to kind of forcefully let the fetus out, in that case, I can damage my lower trunk. Okay. Similarly, for the adults, while grabbing a tree branch, I will suddenly cause the abduction of my arm. Right? In order to grab the tree branches while falling from it, I will suddenly abduct my arm. In that case, I can superly stretched or damaged my lower trunk also. In that case, most because the C8 and the T1s are get damaged, the defects will be more distal, not the proximal. Okay, and the C8 and T1 are mainly involved in the hand part only, not in the forearm, not in the arm. So what I can get is the loss of all the lumbricals, the median nerve and the later and the ulnar nerve lumbricals, they will be lost. The interossei will be lost. The thenar and the hypothenar will be lost. So what I can get is a total kilohen because of loss of all the lumbricals. I will get the hypertrophy or the atrophy of this hypothenar eminence. This is a thenar eminence and this hypothenar eminence, right? And yeah, that's all about it. And this is known as the Klumpke's paralysis. It happens because of a C8 to T1 nerve root dissections. Is that okay?
Yeah.
Okay, then you have a thoracic outlet syndrome, okay, which is similar to that of Klumpke's paralysis. Whenever you have any tumor which is involving your lungs, for like say a Pancoast tumor, which is from the upper lobes of the lungs, okay, because the lower part in your brachial plexus is the trunk, this part. If I get any kind of a tumor, okay, which is extending up to my neck, then first it will compress my lower lobes, the lower trunk, right?
Yes.
Is that okay? In that case, I can also get the Klumpke's paralysis like thing. Okay. What I can get is the same as the Klumpke's paralysis. Okay. It will be because of the compression of the lower trunk and the subclavian vessels. And because the subclavian vessels are being compromised, where can I expect the edema? In the hand, in the upper extremity, right? I will have an upper extremity edema along with the Klumpke paralysis. So if you encounter if you encounter a case of a patient who is having this Klumpke paralysis along with the upper extremity edema, that means it is not a normal Klumpke paralysis but a thoracic outlet syndrome. Is that okay?
Yes.
You can also have this thoracic outlet syndrome with an with an extra set of ribs known as a cervical ribs. Okay, in that case, my nerve can get compressed with this with these ribs, the cervical ribs. In that case, the patient can also have the thoracic outlet syndrome. So, if the patient gives you a history of a presence of an extra rib, right, then you can immediately know the patient is having a thoracic outlet syndrome. In that case, a patient will be having a edema as well as the clumsy paralysis. Is that okay?
Yes.
Then you have a loss of this. This is known as a long thoracic nerve of Bell. Okay, it is formed by the branches. Sorry, it is formed by the nerve roots C5, C6, and C7. Okay, C5, C6, C7. They will join and they will form the long thoracic nerve of Bell, which supplies your serratus anterior. And the serratus anterior muscle is involved in the abduction of arm more than 100 degree, as well as stabilizing the scapula. In the scenario where I got damage of this serratus anterior, which means this long thoracic nerve of Bell, what I can have is a loss of this abduction of my arm above my shoulders, which means more than 100 degrees, 100 degree, right? As well as I will get the winging of the scapula. Okay, very important. The winging of scapula will be present, as you can see, like that. This kind of a prominence will be seen on the back of my body, right? Whenever I try to forcefully, push against the wall, okay, I will get this type of winging of the scapula, and I will also get the loss of abduction in the overhead movements. Okay, and the damage to this long thoracic nerve of Bell can happen while doing the axillary lymph node dissection after the mastectomy. Okay, or any kind of a chest tube insertion, I can damage this also. So a breast cancer, okay, or a chest tube insertion, I can damage the long thoracic nerve of Bell. In case of axillary lymph node dissection, I can either damage my this intercostobrachial nerve, or I can also damage the serratus anterior nerve, right?
Yes.
So any doubt on this page?
No, thank you.
Okay, so that would be everything about the damage to the brachial, this brachial plexus. Okay. Then the wrist region. In the wrist, you have some set of bones. Okay, and these are the scaphoid. This is a long bone, as you can see here. These are the scaphoid, the lunate, the tracheotomy, and the pisiform on the proximal side. On the distally, you will be having a trapezium, trapezoid, capitate, and hamate. And you can remember them by the mnemonic, she looked too pretty, try to catch her. That's how I remember that. For the proximal, scaphoid, lunate, tracheotomy, and the pisiform. Okay, in the distal part, you will be having the trapezium, trapezoid, capitate, and hamate. And how to locate a scaphoid or the lunate bone on the X-ray, because here you can see you have this marked bone, so you can easily identify them. But on the exam, because no bone is marked, so you need to identify somehow, right? So you will look at the radius. Okay, the broad base, as you can see here, the broad base bone is the radius one. On the lateral part of the radius, which means towards the thumb side, you will be having a scaphoid, and on the medial side of this radius, you will be having this lunate bone. And that's how you can easily identify which bone is scaphoid and which bone is lunate. On the scaphoid, you will be having two bones. One is a trapezium, and second is the trapezoid. The rest remaining bones, which is the tracheotomy, and above the tracheotomy, you will be having the pisiform. Okay, so you will be having this bone, the tracheotomy, and over this tracheotomy, you will be having the pisiform bone. On the distal part, you'll be having on the most laterally the hamate bone, and the medial to hamate, you will be having the capitate. That's how you will identify these bones in the X-ray of wrist. Is that okay?
Yeah.
Can you repeat the
And now
mnemonic
let's
you
discuss
said?
about she looked too pretty, try to catch her. She for scaphoid, look for lunate, tri for triquetrum, pretty for pisiform, okay, tri again for trapezoid, two for trapezoid, okay, catch for capitate, and her for hammer.
Okay, thank you.
Okay, I think this so long to pinky, here comes the thumb, is kind of a complex type of mnemonic. So yeah, I remember the easy one. Okay, now the scaphoid bone, which is the most common bone that damaged in your wrist. Okay, you can even feel this wrist in the anatomical snuff box, and these are the markings for the anatomical snuff box. Okay, you can feel this bone here very easily, and this is the most common bone whenever you have any wrist damage, whenever you have any kind of fracture to the wrist. This is the most common type of bone damage. And if you look at the blood supply of this bone, can you tell me uh, what blood vessel can supply this bone?
Radial artery.
Yes, the radial artery. Okay, and just give me a second. Yeah, the radial artery goes like this. They will first go like this, okay, and then they will give a branch, which will, like give supplying this scaphoid like this. So direction of blood supply is happening from distal to the proximal location. Okay, and it is known as a retrograde blood supply. Okay, this kind of blood supply happens with the scaphoid. So in a scenario, if you somehow get a damage of the scaphoid, if you get a fracture of the scaphoid, okay, then this blood supply will be damaged, right? And what you will get is the avascular necrosis of the proximal segment of the scaphoid. Is that okay?
Yes.
In a scenarios, if I get the fracture of my scaphoid, then the proximal segment, because it will be it will become devoid of any blood supply. Okay, so what's going to happen to them? It will be the avascular necrosis of the proximal segment of the scaphoid, right? So please remember that in case of a scaphoid fracture, you will be having a avascular necrosis of the proximal segment of the scaphoid, right? Any doubt on that part?
No, thank you.
And yeah, the locations or the markings for the anatomical snuff box, you will be having the opponent's pollicis brevis and the adductor pollicis brevis. So two brevis muscles, both are for the thumb, right? The opponents and the abductor. Okay, in between these two tendons, you will be having the anatomical snuff box where you can easily feel the this scaphoid bone. Okay, then you have this hamate bone, okay, which is here. You can locate it here in the hamate bone. And whenever I get any kind of fracture of this hamate bone, because ultimately my ulnar nerve passes through here like that. Okay, and this is the Goins canal where my ulnar nerve get passes. Okay, this kind of a canal is present between the triquetrium and this hamate bone, or the pisiform and the hamate, I think. Okay, and the ulnar nerve passes through it. In a scenario, if I get a damage to my ulnar, this hamate bone, okay, any fracture to my hamate bone, if it happens, in that case, my ulnar nerve get compressed. Okay, and it is known as a Goins syndrome. Just like the carpal tunnel syndrome, I'm having a Goins canal syndrome. Okay.
Yeah.
Any doubt on that part? And then you have the dislocation of the lunate. Excuse me a second. Then you have the dislocation of the lunate. If the dislocation of lunate happens, then you need to know that a carpal tunnel is formed between the scaphoid and the pisiform. Okay. And in case of a dislocation to the lunate, my median nerve passes very close to it. Right. And when a dislocation happens, in that case, my median nerve can get compressed and it can cause a carpal tunnel syndrome. So dislocation of the lunate is also a cause of the carpal tunnel syndrome. So if you encounter a patient who is having some kind of wrist trauma, and now he is having a spasms of the thenar eminence, okay, and so you can note that the patient is having a damage to the lunate bone. Is that okay?
Yes.
So with the hamate, I will be having a Gans canal syndrome. With the lunate, I will be having the carpal tunnel syndrome. With the scaphoid, I will be having the avascular necrosis of the proximal segment. Okay, just 3 things you need to remember from this wrist region. Okay.
Yeah, do we have to remember the those boundaries of the triangle?
No, it's just for the information purpose. You don't need to remember. Don't worry, Stubborn won't ask you. It's just for a more clarification on the topic, right? That this scaphoid is present here at the exact location if you want to feel.
Okay.
Okay.
Thank you.
And this is the fracture of surgical neck of the humerus. Okay. As you can see, the axillary nerve passes through the surgical neck. If you get any damage to the surgical neck, then the axillary nerve will become paralyzed. And apart from the axillary nerve, you also have the artery, the axillary artery. Okay, which is a continuation of which artery?
Subclavian.
Subclavian artery. Subclavian artery will become the axillary artery, and this axillary artery gives up 2 branches. One is the anterior circumflex artery, and second is the posterior circumflex artery. Now they form a bridge between the humerus and the axillary artery. Okay, and this bridge is called the humerus Sorry about that, my internet connection has been lost for some duration. Now we are back again. Am I audible?
Yeah.
Yes.
Okay, so along with the axillary artery, you also have the along with the axillary nerve, you also have the posterior circumflex artery and the anterior circumflex artery supplying the surgical necks and the proximal part of my humerus. Okay, if I get a damage of the surgical neck, then you must know that just like my scaphoid, okay, in which the supply of the blood will be happening from proximal to distal location, right? Similar to my humerus, the blood supply will be happening from. So in that scenarios, if I get a surgical neck of humerus fractured, right, in this case, the avascular necrosis of this head of humerus will occur. Is that okay?
Yeah.
In a scenario, if I get a surgical neck of fracture, right, in this case, I can have a avascular necrosis of the humerus, head of humerus, because of the loss of blood supply by the anterior and the posterior this circumflex arteries. So what I can have because of this avascular necrosis, I will be having so much pain. I will be having a decreased range of motion, right? Flattening of the humerus head will be seen on the X-ray, right? And I can also get a deltoid flattening because of loss of this nerve supply to them, right? And fever would be there, very tender uh, area would be there over the shoulders, right? So these are symptoms whenever you get the fracture of the surgical neck of humerus. Is that okay for everyone?
I have one doubt.
Yes.
What's the meaning of flattening of the humeral head?
It just because of the atrophy and because of this necrosis, it will appear like the flattening of this head has been occurred because of necrosis, right?
Okay, okay, yeah, I got it now.
Yeah.
Thank
And then comes the hands muscle. Okay. And first you have the thenar eminence. Every muscle to a thenars will be pollicis. Okay. You have the opponent's pollicis. You having the abductor pollicis. Having the flexor pollicis. Okay. 3 opponents, abductor, and the flexor pollicis. Same goes for the hypothenar. Okay. For the hypothenar, you use the word minimi. Okay. So opponents, abductor, and the flexor digiti minimi. Digiti because it's supplying the digits. Opponents, the pollicis because it's supplying the thumb. We use the word pollicis for the thumb and the GT for the digits. Okay. So opponents, abductor, flexor, pollicis brevis. Opponents abductor flexor digiti minimi for the hypothenar. The thenar eminence supplied by the median nerve and the hypothenar supplying by the ulnar nerve. So they're kind of a very much parallel function to each other, right? As you can see, all the functions which are supplied by the median nerve, the same functions are supplied by the ulnar nerve, but at different locations, right?
Yeah.
And then you have the dorsal interossei and the palmar interossei, okay, which causes the abduction and the adduction of the fingers. Okay, if you want to kind of move your fingers away from each other, which means the abduction, it is done by the dorsal interossei. If you make your finger close, okay, like raising a hand, in that case, you will be abducting your fingers. It will be done by the palmar interossei. The lumbricals you have in the hands, okay, the first and the second lumbricals are supplied by the median nerve, and the third and the fourth lumbricals are supplied by the ulnar nerve. Okay, so you can remember the function of the dorsal and the palmar interossei by the fact by this mnemonic dab and pad, which means dorsal abduct and the palmar it adduct. Okay, so dab and pad, you can remember the mnemonic for the function of dorsal interossei and the palmar interossei. So thenar muscles, hypothenar muscles, lumbricals, and the interossei. The four group of muscles are exist in your hands. Thenar is all the functions of the thumb. Hypothenar for the function of your fingers, little one especially. Okay, interossei is for the abduction and adduction of the fingers, and lumbricals for their own purpose, right? Any doubt on this part? The hand of muscles, the hand muscles.
No, thank you.
Okay, so next part, which is the distortion of the hand. See, whenever you have any proximal damage of the of any nerve, the median nerve and the ulnar nerve we're talking about. Whenever you have any proximal damage, in that case, okay, in case of a distal damage, because the proximal muscles are still working, that the symptoms will be more pronounced. What I'm saying is, if you think about a median nerve, let's say, the median nerve supplies the structures in your forearm, right, which are responsible for the wrist flexion and the finger flexion, right?
Yeah.
And then again, my median nerve supplying the structures in the hand, which are responsible for the extension of the PIP, DIP, and the flexion of the MCP. Is that okay?
Yes.
So if I get a proximal damage of this nerve, the median nerve, in that case, the muscles from my forearm, which were causing the flexion of these fingers, they would be lost, right? Please respond, Rez. If I got a proximal lesion in my nerve, then the nerve supplying then this nerve supplying the forearm structures, which are causing the flexion of my fingers, it would be lost.
Forearm muscles are causing flexion of the fingers.
Yes.
Yeah, of course. The origination of these muscles is from the forearm.
All right. Okay.
Okay. Just give me a second again. Yeah. So in this scenario, the flexion of my fingers is lost. And now the supply of the hand is also lost, which means the lumbricals. So now I cannot have the flexion. I cannot have this kind of extension thing. So symptoms are kind of, balancing each other, right? It is not very much profound. Only when I try to move my hand, I can see the this effect of the paralysis. Are you getting my point?
Yeah, yeah.
But if I get a distal damage of the median nerve, let's say after the wrist, in that case, my lumbricals are lost, but the muscles which are causing the flexion at my fingers, the forehand muscles, they're still working, and they will cause a very profound this flexion at my fingers. Because when the extension is lost, I will get a very profound flexion, right?
Yeah,
Like
yeah.
this claw. So as you can see, whenever I'm having a distal damage, I will be having a very profound symptoms. And whenever I'm having a this proximal damage, I'm having a very less symptoms. Symptoms will only be there if I move the hand in case of proximal lesion, and symptoms will be there even at the rest if I get the damage to the distal nerve. Yes.
Yeah.
So that's what the FA writes. The defect is less pronounced whenever the proximal lesions happen, and defects will be more pronounced whenever distal lesion is happen. right? And clawing, which is best seen with the distal lesions only. Okay, even at the rest, you can see the claw. If you see, if you're having a very distal damage, you won't see the claw at rest. If you're having a proximal damage, is that okay?
Yes.
So now let's discuss about the ulnar claw. Okay, and in which context, in which extending fingers or at rest, even you can get this, and it is because of a distal ulnar nerve. When you get a damage to distal ulnar nerve, okay, you're still having some muscles in your forearms which are causing the flexion of the this fourth and the fifth finger, right?
Yes.
And the nerves or the name of the muscles, I think it was the flexor digitorum muscles, right?
Yeah. Superficialis and profundus.
Yeah, and all of these muscles are originate in the forearm. And now you get it, right?
Yeah. Yeah. I get it.
So these muscles will still causing the flexion, right? But the lumbricals are lost. So what I will get is the claw even at the rest because of the hyper flexion of these muscles by these of these fingers by these muscles, right? In the second one, if I get a proximal median nerve damage, okay, then what's gonna happen? All the muscles, uh, the flexor digitorum muscles which are causing the flexion at my first, second, and this third part of the fingers, okay, they will be lost as well as the lumbricals will be lost. So they kind of balance out each other. So I won't get any symptom on the rest. But when I ask my patient to make a fist, and to make a fist, you need the muscles, the flexor digitorum muscles, to cause the flexion at the fingers, right? But they cannot cause the flexion. And as a result, on the on making a fist, I can get this ulnar claw again, or it is known as a Pope's blessing. Is that okay?
Yeah. Yeah.
Yes, sir, that makes sense. How proximal is proximal? Like, can you point on the hand about like where the lesion would be?
In the arm, or at a very early part of your forearm, okay, just before the antecubital fossa. Because in the antecubital fossa, you will be giving the radial nerve branches and other, right?
Mm-hmm.
So before the antecubital fossa, if you get a damage, then you will call it a proximal nerve damage, right? After the antecubital fossa, you will be having this the anti-interosseous nerves and other nerves which will supplying these other muscles. So you won't get these symptoms in that, right?
Okay.
So in a very early forearm or in the arm, if you get a damage, you will call it a proximal damage. After the antecubital fossa or any distal part of your arm, you will call it distal lesion, right?
Okay. Okay. Thank you, sir.
Similarly, if you get a distal median nerve damage, in that case, my nerves, the flexor digitorum muscles, okay, they will be causing the flexion at my first and second finger, right? But because the lumbricals are lost, I cannot cause the extension. So what I get is a hyperflexion here. What I can get is the median claw, you will call it. And you can see this even at the rest without doing anything. Okay. In case if I get a proximal ulnar nerve damage, okay, then similarly, I will having a loss of function of the flexor digitorum muscle supplying the fourth and the fifth finger as well as the lumbricals there. Okay, so I won't get any symptom at the rest. But when I ask the patient to make a fist, okay, they will be easily flex the first, second, and the third finger, but they cannot flex the fourth and the fifth finger because the ulnar nerve is now lost. What you will get is the okay gesture. Is that okay?
Yeah. Yeah. Cool.
So this is all about the distortions of the hand. And if I go back, I have written it here, the hand muscles, the function of all the hand muscles. See, for the extensions, for the wrist extension and the wrist flexion, okay, you call the nerves, you call the muscles extensor carpi radialis and the flexor carpi radialis or the ulnaris. Okay, the radialis part is supplied by the median for the flexion, and the ulnaris part supplied by the ulnar for the flexion. The extension part is supplied only by the radial nerve, which means the extensor carpi radialis and the extensor carpi ulnaris. Both are supplied by the radial nerve. The flexor carpi radialis supplied by the median nerve, and the flexor carpi ulnaris supplied by the ulnar nerve. Is that okay?
Yeah. Yeah.
Now this radialis muscle is of two types, either the longest one or the brevis one. So the name extensor carpi radialis longus and the extensor carpi radialis brevis. Okay, and these muscles are these three muscles for the extension and the two muscles for the flexion. This is a muscles for the wrist. Okay, then you have muscles for the phalanx. Okay, and you call them the digitorum muscles. All of them goes by the name digitorum. For the flexum, you will having a flexor digitorum superficialis and the flexor digitorum profundus. Okay, for the superficialis, it will supplying the PIP, which is a proximal interphalangeal joint, and the flexor digitorum profundus supplying the distal interphalangeal joint. Similarly, you will be having an extensor digitorum supplying both the PIP and the DIP. Okay, for the little finger, the fifth one, you have a special muscle, extensor digiti minimi, okay, supplying it. And you need to know the function of all of these muscles. Very important nowadays. Stephen started asking questions about these muscles. Okay, so you do have to remember the functions of all of them. Okay, in what part you will get, especially these digitorum muscles. What muscle supplying the PIP, what muscle supplying the DIP. Step one will give you a scenario in which the patient damages superficialis muscle and they will ask you flexion at what part would be lost, right? So you need to remember these functions, every muscle. Okay, so for the hand, they will always go by the name carpi. Okay, for the wrist and for the phalanx, they will go by the name digitorum. So carpi and digitorum. Okay. Any doubt on that part?
I have one question.
Yes.
The extensor digitorum and the extensor digiti minimi, they are also supplied by the radial nerve.
Yeah, all radial.
Okay, yeah. Got it.
Extensor
Okay.
part is only supplied by the radial nerve.
Okay, thank you.
Okay, and let me think if I'm not missing anything more. Yeah, that would be it. And do remember about the thenar and the hemipothenor eminence, which are the opponents, abductor, and the flexor. Three group of muscles: opponents, abductor, and flexor. So, any doubts so far about the hand?
No, thank you.
Okay, so we are finished with the upper limb, and now we will study the lower limb after a short break. Okay.
Sorry.
Yes.
We are finished the upper limb, now the lower limb after a short break.
Sure.
Okay, now you need to know about the thigh muscles, and first are the anterior compartment. Okay, all the muscles in the anterior compartment at the hip, they will cause the flexion. Okay, and at the knee they will cause the extension. So at the hip they will cause the flexion, and at the hip and at the knee they will cause the extension. The important muscles which are involved includes the iliopsoas muscle, which are made up of two muscles, the iliacus and the psoas. Iliacus muscle, as you can see here, this part muscle, this is the iliacus, right? And the psoas muscle, it came from your spines, from the abdomen. Okay, so iliopsoas muscle, it will form and it will cause a flexion at your hip first. And second thing, it will cause the external rotation at your hip. Okay, so flexion and the external rotation, this is the function of uh, this muscle, the iliopsoas muscle. Okay, second is the rectus femoris. As you can see, this muscle, the rectus femoris, it is involved in the flexion of the hip because it is it attached at the crest of the ilium. Okay, and then go all the way to the knee. So it causes the flexion of the hip as well as the extension of the knee. Okay, then the third muscle you have is the sartorius muscle. Okay, as you can see, this is the sartorius. Okay, it goes from the iliac crest and attaches at the medial side of your this bone, right? And it causes the flexion of the hip and the knee first, because it is attaching kind of very much posterior and medial, right? So it is involved in the flexion of the hip as well as flexion of the knee. And second, because whenever this muscle contracts this way, whenever the muscle contracts this way, right, what it will cause? the external rotation of the thigh. Is that okay?
Yeah.
So please remember the function of these three muscles. These are the most important one. The iliopsoas muscle for the flexion of the hip, as well as the external or the lateral rotation of your thigh. Second is the rectus femoris muscle for the flexion of the hip and the extension at the knee. Sartorius muscle for the flexion of hip, flexion of knee, as well as the external rotation of the knee. Okay. Then you have other muscles of the thigh also, like the tensor fascial, this muscle, the tensor fascial artery, the vastus lateralis, vastus medialis, the vastus group of muscles. These are all involved in only the this extension of the knee. They do not cause the flexion of the hip. They just cause the extension of the knee. Only the rectus muscle, this vastus lateralis, the vastus medialis, and the rectus femoris, they all form a group of muscles known as quadriceps muscles. Okay. And apart from them, and in these muscles, only the rectus femoris has attachment at the hip, and that's why it causes the hip flexion. Whereas the vastus lateralis and the vastus medialis, they do not cause the hip flexion, they just cause the knee extension. Is that clear up to here?
Yes.
Good. And now comes, give me a second again. Okay. Let me share the screen. Okay. Now, this is the posterior of your thigh. Okay, just important muscles which you need to look for the step one are the piriformis and the obturator. You know the location. See, this is your piriformis muscle. Okay, as you can see here, and this is your obturator muscle, a very small. Okay, the obturator externus. Okay, and whenever these muscles contract, they will cause the lateral rotation of the thigh. As you can see, whenever these muscles contract, whenever these muscles contract this way, they will cause the external rotation of the thigh. Is that okay?
Yes.
As well as because they're attaching on a very superficial look at the very top of your thigh, okay, of your femur. Okay, so whenever these muscles contact, they will always always kind of will cause the abduction of your thigh also, like this, right? They will move your thigh away from the central line, so they will cause the abduction of the thigh, and they will cause the lateral rotation of the thigh. Is that okay?
Yeah.
Two functions, the lateral rotation as well as the abduction. Then comes the gluteus medius and the gluteus minimus. This is the gluteus medius muscle, and this is a gluteus minimus muscle. Whenever these muscles contract, they will first cause the abduction of the thigh. Okay, they will move away your thigh from the central line. Second thing, they can cause the medial rotation. Okay, because they kind of attach very anterior. Okay, so whenever these muscles contract, they will actually cause a medial rotation instead of lateral rotation. Okay, so a medial rotation, abduction, and as well as these muscles are involved in the stabilization of your pelvis. Is that okay?
Yeah.
And finally, you have the gluteus maximus muscle, this one, the largest one. Okay, it causes the extension at your hip, right? It causes the rotation, the lateral rotation of your hip. Okay, as well as the abduction of your hip. Okay, so gluteus maximus for the extension, for the abduction, and for the lateral rotation of your hip. Is that okay?
Yes.
So let me share my screen again. These are the important muscles of the thigh. Okay, the posterior hip and the anterior hip. For the posterior hip, they all cause the extension. For the anterior hip, they all action. Some of them can tilt rotation, gluteus maximus. Okay. Is my voice okay?
Yes.
Okay. So any doubts so far on this page?
Could you please repeat what you said on this page?
It's just about the posterior hip and the anterior hip. You have the muscles for the posterior. All the muscles causes extension, and the of the causes the lateral rotation. Some of them can
Can't
cause
hear you.
the rotation.
Breaking up.
The rotation making. Okay, I don't know. I think then it's a connectivity issue from my side. Okay, so you have the posterior hip, you have the anterior hip, right? For the posterior hip, all the muscles which are present here, they causes the extension at your hip. For the anterior hip, all the muscles present here causes the flexion of your hip. Some of the muscles of the posterior hip can cause the external rotation. Most of them cause the external rotation. Some of them can also cause the internal rotation. The internal rotation ones include the gluteus medius and minimus. Rest of the muscles, the piriformis, obturator, gluteus maximus, they causes the external rotation or the lateral rotation. The muscles in the anterior hip, they all causes the flexion. Okay, apart from that, some of them can cause the internal rotation, some of them can cause the external rotation. The ones that can cause the external rotation includes the iliopsoas muscles, and the ones that can cause the again the external rotation includes the sartorius muscle. Is that okay?
Yeah.
So now let's go to the second page, which is the action of different hip muscles. The abductors, as we have discussed already, the gluteus medius, gluteus minimus are the abductors of your thigh. Similarly, maximus can also be the abductor, but the major ones are these two. Okay. Then the adductors, all the muscles which goes by the name adductor, like the adductor magnus, longus, and brevis, they all can cause the adductions. Okay. Then you have the extensor muscles, okay, which can cause the extension at your hip. And we have discussed that already, the gluteus minimus muscle. Okay, the other muscles include the semitendinous and the semimembranous. Okay, these muscles can cause the extension only. Then you have the flexors of the hip, like the iliopsoas muscle, the rectus femoris, okay, tensor fasciae latae, pectineus, sartorius, right? All these muscles can cause the flexion at your hip. Okay. Then you have the internal rotations. Okay, you have the gluteus medius for that, gluteus minimus for that, tensor fasciae latae for that. Okay, we have discussed that already about the gluteus minimus and the gluteus this medius. They can cause the internal rotation. For the external rotation, for the anterior side, you are having this iliopsoas muscle. Okay, for the posterior side, you will be having the gluteus maximus, piriformis, and the obturator. Is that okay?
Yeah.
Good. And yeah, for the hip flexors, remember the iliopsoas, they can only cause the hip flexion. Rectus femoris can cause both the flexion of the hip as well as the extension of the hip. knee, and the sartorius can cause the flexion of the hip and knee, as well as the external rotation of the thigh. So step 1 will give you a scenario in which a nerve to these muscles could damage, and they will give you some of the distortions that is happening because of the nerve damage, and they will ask you what muscles are being paralyzed because of that, right? So you need to identify by looking at the actions of these muscles. Okay. Then you have the psoas abscess, okay, which is because and you know that the psoas muscle is a major hip flexor, right? In case of any kind of abscess or any kind of damage to this muscle, okay, what can happen? First of all, because of the necrosis or the abscess, you will be having a fever, you will be having a back pain or a flank pain, right? And you will be having a psoas sign, in which whenever you try to extend the hip, okay, or whenever I try to cause the flexion of the hip against a force, which means whenever you try to resist the flexion, you will have the pain. Very important. This is a psoas sign because a psoas muscle is involved in the flexion. So whenever you extend your hip or whenever you try to resist the flexion, you will have the pain. Okay. And this abscess can develop because of any hematogenous route, in case if you're having any systemic bacteria for like sepsis case. And remember, I told you that point, whenever a bacteria gain access to your blood, it can go anywhere, right? If it can go to your psoas muscle, it can cause the uh, abscess there. Similarly, lymphatic seedings can also occur. Okay. And if you're having any osteomyelitis in the nearby area, then that osteomyelitis can also cause the psoas sign, right? And the psoas abscess or the psoas sign can also be available in the case of appendicitis. Remember,
Yes.
if the appendix is rectocecal type, in that case you can have the psoas abscess, right? You will have the inflammation of the psoas, you will have the irritation of the psoas, and you will have the psoas sign, in which your hips will become very flexed, and you will have the pain on the extension. This is a psoas sign. Okay, so remember about this. And the biceps femoris, semitendinous, semimembranous, these are the hamstring muscles group. Okay, and they're involved in the hip extension and the knee flexion. Okay, very important. And and the hip extension is done by the semimembranous and the semitendinous, mainly these two muscles. Okay, so that's everything on this page. Any doubts so far?
No, thank you.
Okay. Yeah, someone is asking something.
Yes, I got a question. If in the test they give you like the scenario that the patient got so abscess and they ask you what the patient cannot do, so you put extension, right?
Exactly, extension or a flexion against the resistance.
Okay.
That's what
Thank
you will
you.
answer. And they can also ask you the location of the hips flexors, where they originate, especially these adductor muscles. Very important. These adductor muscles, because they need to abduct your thigh. That means they need to be originated from a center line, right? From the center point of your body. That means the ischium. Okay. Very important. Are we good with that?
Could you please repeat?
See, all these adductor muscles, let me open the page again. Yeah. All these adductor muscles, right? Adductor longus, adductor magnus, adductor brevis, right? All these adductor muscles, they need to adduct your thigh, right? Which means they must be originated from a medial line, from a central line, right?
Yes.
So these muscles, they generally originate from the ischium of the bone. You have three hip bones, ilium, ischium, and pubis. The origination of these adductor muscles are from the ischium. Okay, you don't need to remember this fact, but just get a sense that if the muscles need to cause a abduction, they need to be central, right? Even if you forget this point, then you will have a location, right? You will have a location in your mind which is central location. And the step one will give you some example like the ilium, like the and some more later locations they will give you, and but you need to choose the most medial one, right, which is the ischium, if you guys remember that.
Okay, yeah. Thank you.
You don't need to know the exact location, just have an idea where the muscles are originating. If you look at the diagram, you can easily get the idea, right? So yeah, that's everything for here. Any doubts so far now?
No, thank you.
Guys, can we take a leave now?
Yeah, sure.
Okay. Thank you so much, everyone. We will study these extremity muscles and the lower extremity muscles from tomorrow. Okay. And I think we will able to reach the pathology. Yeah, we will able to reach the pathology tomorrow. Okay.
Thank you.
Thank you so much.
Thank you.
Thank you.